So, hello, good evening, and namaskar. It's a great pleasure to welcome you all for this exciting session. And this is very well designated as WFO Women for Oncology, the Lung Cancer Update. I'm sure I'm not stealing the show from Dr. Kanika Sood and Dr. Runu, madam. And before I give the floor to ma'am, first of all, happy Navratras, Vamnavi, and in advance, happy Dashera to everyone. So, once again, good evening, and I give the floor to you, Dr. Kanika Sood, ma'am. She is well known as Director and Clinical Lead, Radiation Oncologist at the prestigious Dharamshira Narayan Hospital, Delhi. So over to you, Dr. Kanika, ma'am, for your words and setting the context for today.
So thank you, Tarunji, for that introduction. And I must say a very, very opportune moment. Well, the entire country is celebrating this Sri Shakti, and I think the scientific community celebrates this Sri Shakti in a different manner. So we are having this academic meet, well partnered by, Astra, Glenmark and Sun, and Intas, who are supporting this meeting. And it is a topic which is very pertinent. As we know, lung cancer per se is on a rise, and we are seeing more cases in the non-smokers. There's been a 50% rise in lung cancers in non-smokers as well. These non-smokers tend to have more driver mutations, so more and more options of treatment are coming into picture with the availability of the newer biological agents. So we will have a lot of discussions about those agents, and we will also have discussions about how the role of radiation has redefined itself in the era of the systemic treatments. And with Astro and ASCO updates bringing in more light on how the integration may happen, we will have a lot to discuss today evening. So without wasting much time, I would invite Dr. Runu Sharma, who is a senior medical oncologist. She is from Max Dehradun, and she will be bringing in her first topic of presentations for today's evening. Over to you, Dr. Runu, on EGFR in the metastatic non-small cell lung cancers.
Hi, thank you, ma'am. And good evening, everyone. As ma'am has already introduced me, I'll quickly move on with my presentation. So today I'll be talking about the FLORA-2 study, raising the bar of EGFR mutated metastatic non-small cell lung cancer. And this talk will highlight the scientific rationale in the study design and the latest results of FLORA-2, and we'll discuss how this impacts our daily practice. So EGFR mutations occur in about 40% of the Asian patients as compared to around 20% of the non-Asian population. And the most common alterations are the exon 19 and exon 21 L858R. In the Indian population, the incidence is around 30 to 40%, and these mutations, they drive the tumor growth through the activation of the EGFR pathways, making the targeted therapy the cornerstone of the treatment. So, while the first and the second generation TKIs have improved the progression-free survival, resistance inevitably develops. So, even with osimertinib, the third generation TKI, the resistant mechanism limits the durability, and the overall survival remains to around 3 years. So, the key question is, can we further improve the outcome by combining the TKIs with chemotherapy? So when treating the EGFR mutated NSCLCs, why we need to combine the therapies is to improve the overall outcome. We need to further improve the outcomes in the EGFR mutated patients, especially in those who had CNS metastasis upfront. So with this idea in mind, these two trials, NEJ009 and the TMH study, at the similar time evaluated the role of EGFR TKIs first generation in combination with the chemotherapies. And they found that with the combination, the progression-free survival was almost double. It was around 20 to 18 months compared to 11 to 8 months with the monotherapy. So the key questions that we ask when we select the treatment is whether the treatment is going to improve the progression-free survival, the overall survival, whether the treatment will be effective for those who have CNS metastasis and for different EGFR subtypes. What about the co-mutations? What about the mechanism of resistance that will develop? How prolonged will the treatment be? And what are the safety profiles, whether it will be well tolerated by the patient, and how convenient is it going to be for the patient? So with all these things in mind, the FLORA-2 phase 3 open-labeled randomized study evaluated the combination osimertinib along with the platinum and pemetrexed doublet chemotherapies, followed by osimertinib and pemetrexed as a maintenance, versus the monotherapy with osimertinib. So their primary endpoint was progression-free survival, and the secondary endpoints were PFS2, the disease control rate, overall survival, and the quality of life. So around the study enrolled around 800 patients across 21 countries, and the baseline characteristics were well matched in both the study groups. And what is more important here is to highlight that around 40% of the patients had CNS metastasis at baseline, which highlights the higher risk population being enrolled in the study. And coming to the progression-free survival, we can see here that the PFS of at 2 years, median PFS was around 60% with the combination therapy versus 40% with the osimertinib monotherapy, with the hazard ratio of 0.62. So the median PFS benefit with the combination therapy was around 8.8 months. Again, with the independent central review, we can see here the similar results with the similar PFS advantage and the median PFS benefit of around 9 months. And here again, we can see the early separation of the graphs, which shows that the benefit started early during the course of therapy and the benefit remained throughout. And in fact, there was the more widening of the separation curves as the time progresses. So the benefit of the combination therapy was consistent across all the subgroups, be it the gender or the Asian or non-Asian populations, and of course also along the different EGFR mutation subtypes. But the maximum benefit which we can see here is for those who had CNS metastasis as baseline, where the hazard ratio was 0.47. Coming to the updated overall survival, the median OS with the combination therapy was around 47 months, with the OS benefit of gain of around 10 months with the combination therapy, which is remarkable, which we can see here at the 3-year landmark. We can see that with the combination therapy, the overall survival at 3 years was around 63% versus 50% with the monotherapy. Similarly, at the 4-year point, the overall survival was around 50% versus 40% with the monotherapy. Then similar to what we have seen with the PFS, the OS benefit was also consistent across all the predefined subgroups, be it those with brain metastasis upfront, be it for the EGFR different mutations, with the smoking history for the younger and the older population. Coming to the PFS2, we can see the PFS2 with the hazard ratio of 0.70 again favored the combination therapy. This shows that the benefit of the combination therapy persisted post-progression also, and that warrants the use of the combination therapy upfront. So the best regimen has to be used in the front line. Coming to the tumor response, we can here see that the objective response rate with the combination is around 80% with the median duration of response of 24 months. Again, for those who had CNS metastasis at baseline, we see the early separation of the graphs at the 3 months point with the median PFS of around 25 months as compared to around 14 months with the monotherapy, again with the hazard ratio of 0.47. If we see as when we compare with the measurable and non-measurable brain metastasis, again we see that there was the PFS advantage with the combination therapy, whether we have used the measurable brain metastasis or whether we use the measurable along with non-measurable brain metastasis. At 2 years, we can here see the PFS of around 75% with the combination therapy versus 54% with the monotherapy. There was the higher complete response rate with the combination, with the CNS overall response rate of around 73 to 80% with the combination, and the complete response rate of close to 60%. So the probability of observing CNS progression at 2 years mark was 23% with the osimertinib monotherapy, and this was reduced to striking 9% with the combination therapy. The study also showed that the median exposure to pemetrexed chemotherapy was much shorter with the combination therapy, which suggests that there was a long chemo-free interval when the patient stopped pemetrexed and continued on osimertinib and enjoyed the chemo-free interval. So chemo plus osimertinib showed a long duration of chemo-free period with the median exposure to osimertinib was around 30 months versus just 8 months with the pemetrexed. The chemotherapy that was used at the time of at the time of progression was the platinum-based chemotherapy, and around 44% patients had a re-challenge. And those who were on single-agent osimertinib, they also at the time of progression, around 77% of them went on to receive the standard of care chemotherapy. And despite that, we see the OS advantage with the combination therapy. Coming to the safety analysis, there were no new safety signals observed in the study. The adverse events which led to discontinuation of osimertinib remained very low, and there were no new treatment-related mortality observed with the combination therapy. And also we see that the adverse event onset and the severity, it was highest during the initial period, and it gradually reduced over time as expected. And if we do a cross-trial comparison of FLORA and FLORA-2, we see that the median PFS with the osimertinib is around 19 months, while with the combination therapy in FLORA-2, we saw the median PFS of 26 months. And similarly, with the overall survival, also we see the improvement of 47 months in the combination therapy versus we see around 38 months with the monotherapy. There were again improvement in the CNS progression also, and the toxicity is well managed, was similar in both the groups, and there was improved response seen in the L858R mutation category also, where with these single agent we have seen the PFS of around 14-15 months, while with the combination we are seeing the progression-free survival of around 25 months. So to summarize, I would say the osimertinib plus chemotherapy demonstrates a median PFS of close to 4 years compared to approximately 3 years what we see with the osimertinib monotherapy. With over 2 years of additional follow-up since the primary analysis, we have seen that the safety profile, it remained manageable and expected with no new safety signals. And the OS result from the FLORA-2 suggests that osimertinib plus chemotherapy should be the first-line standard of care for most of the EGFR mutated advanced NSCLC patients. With this, I'll end my slides here and my presentation, and I'll thank you for your patient listening.
Thank you, Dr. Rono. I think it was well timed, well in time, and I think we would have some questions when we have the panel for EGFR mutated tumors. I think we would be able to take them there itself together. So I see Dr. Jyoti has already joined in. So I will request that we can proceed with the next panel, which is on advancements in the next generation sequencing and molecular testing, the way forward. So moderator for session is Dr. Jyoti Vadva, who's the Vice Chairman and Head Medical Oncology at Apollo Women's Hospital. Now for the...
You have mixed up, Kanika, you have mixed up my post and the place mixed up. So I'm, post was there at Paris.
Right.
Senior consultant and lead of medical oncology and precision oncology at Apollo now.
At Apollo. So Apollo is my thing. Rest is
Yeah.
from the
Yeah,
from
from Tarun.
the
Yes,
tech team.
that's
I
all right.
updated the institute because I was aware of that.
Yes, yes. Yeah.
So for the panelists, we have with us Dr. Aparna. She joined in Valentine, Director, Hereditary Precision Oncology and Genetic Counseling at Max Saket. We have Dr. Devnani Niyogi, Associate Professor, Thoracic Oncology from Tata Memorial Hospital. Dr. Runu will be joining in as a panelist for this session as well. And we have Dr. Aarti Mehrotra, who's the Associate Honorary Active Visiting Consultant Medical Oncology at Sir Gangaram Hospital. So over to you, Dr. Jyoti.
Thank you, Dr. Kanika. And I have just entered, and I'm sure to make some mistakes, but we'll manage. Between 5 of us, 5 women, we'll manage. My slides are visible now, right?
Yes, yes.
Yes, ma'am, they are visible.
So we'll keep it simple and practical. And I hope all the 4 panelists are there. I can see Dr. Parna, Devyani, Dr. Runu is there, and Dr. Aarti is also there. Is Dr. Aarti there?
Yes, ma'am, I am there, but I'm traveling. I don't know whether I'll be connected.
Okay, don't
Yeah.
worry.
Yeah,
We'll try to manage. Yeah. So let's begin. So we know that, and lung cancer, especially non-small cell lung cancer, we all agree that there is a definite role for doing the comprehensive genomic profiling, or NGS. And the role has evolved, gone beyond the initial diagnosis as well. During the treatment journey of a patient, we end up repeating it also, and we know the advantages. The liquid biopsy has emerged in a big way and can be really helpful sometimes at diagnosis, but definitely at disease progression subsequently. So we have Dr. Aparna, who is our molecular oncologist and geneticist. Dr. Devyani is a medical oncologist.
No, I'm a thoracic surgeon.
Okay, you are a surgeon. Great. Dr. Runu is medical oncologist, and Dr. Aarti is she a radiation oncologist?
No, ma'am, I'm a radiation oncologist followed by medical oncology.
Okay, great. Okay, so let's begin. So do we all agree for the definite role of NGS in lung cancer? Anyone who wants to comment before we move on? Anyone who's not doing it or is unable to do it for various reasons in 2025? Are we all doing it? What about Dr. Devyani, you, the surgeon? Suppose it's an operable lung cancer, resectable non-small cell lung cancer. What's your approach? Do you involve a medical oncologist in the beginning itself, or?
Yes, we do. So, for all tumors which are larger than 4 centimeter node positive, where we have an established role for neoadjuvant immuno if the patient can afford it, we do end up doing an NGS upfront to rule out molecular marker positive status and guide the neoadjuvant therapy.
Right. So we all agree, including the surgeon, that there is a definite role for doing these biomarker studies, the molecular biomarker studies. So from the medical oncologist, from the clinician, and that could include medical radiation as well as the surgical oncologist, I think there are some challenges that we face in real world, and there are certain dilemmas that we encounter. And I've tried to list some of them. So maybe let me come to you, Dr. Runu.
Yes, ma'am.
What are some of those challenges that you face? Say, I have listed some of them here, and I'll reveal one by one, but you could yourself, start.
Yes, ma'am. So I think the most important challenge that we face is that the insufficiency of the samples that we in our day-to-day practice will end up in, and the exhaustion of the tissue while processing with the biopsies and IHCs. And Of course, there are n number of labs now available in house, so which lab to send, and what kind of NGS do we want? Do we want the lung panel, or we want a broader panel, depending upon how much tissue we have in hand. And finances also sometimes they come into picture, that how much we are able to. But now, since we are having so much of support from the companies also, so that hardly becomes a problem nowadays. At least we can do the basic lung panel for all of our patients. So that is what we are following. And
Right.
yes, of course, the turnaround time becomes an issue, because the patient is so anxious. They want the report the very next day. And when we tell them that it will take time, it might take 15 days, sometimes might take 3 weeks also. In my scenario, sometimes we'll end up in 21 days also, and makes the patient really anxious. So that is the time when we might have to give some kind of a chemotherapy to calm the patient down till we get it that time, we buy the time, so that we get the report in hand and plan the further treatment.
Right. So very true. You have covered even beyond these issues listed here, the challenges. Dr. Aarti, let me come to you now on the same question, since you are also a clinician, a clinical oncologist. So what's your take on this, the challenges that you face? Anything beyond this that Dr. Runu has already mentioned?
Well, ma'am, we since the TAT time of NGS would be a little longer, so we go ahead with chemotherapy in case patient is in visceral crisis. Otherwise, we uh, retain time to and wait for NGS report.
Mhm. Some more challenges like the ones that I have listed here. So do you also stick to basic, at least 12 gene panel for all, and broader panel wherever feasible? Is that your practice also?
Yes, ma'am. Basic, of course, the 12 gene panel. And in case we do not find any targetable mutation and patient is unfit for chemotherapy, then we do go ahead for a broader perspective.
Right. And how often, both Dr. Runu and you, how often do you encounter now sample not sufficient? How often are you, facing this issue of sample not being sufficient, and therefore the patient either requiring a liquid biopsy or a repeat tissue biopsy?
Ma'am, there are times when the tissue gets exhausted, when we have done repeated sampling. That is, of course, when the patient has reached to a third line or fourth line, where we reassessing for any other mutation that is possible. But usually we do get a sample, because at the prima facie we send the sample for NGS, and we make sure when the biopsy is done that there enough sample is been withdrawn, uh, and we store it for the testing.
Right. Dr. Devyani, would you like to add something here?
No, I think you've summed it up quite well, and these are real challenges. But I think of all, the turnaround time is something that makes the patients quite nervous, because you don't really start their treatment after giving them a diagnosis of lung cancer. So I think that would be the biggest challenge that we face.
Yeah. So true, and we must not be adding, we may start chemotherapy if indicated, if the patient's symptoms or the tumor burden so desires, but the immunotherapy should be withheld till we
Yes.
get the biomarker report. So very true there. So let me come to you, Dr. Aparna, now. So I'm sure you, being a molecular oncologist, also face challenges as regards the NGS or CGP in your practice. So what are some of those challenges that you see, in a patient with lung cancer?
So good evening, everybody. I think one of the main challenges we face is with the quality of the report. A lot of times, this is very do we get a good sample? That is always the tissue can be an issue. It's not accessible, but quality of lung is, I think somewhere we know liquid biopsy is a great sample type that can be used for calling out the mutations. But I think the key issue that we face is, while we've kind of acknowledged that these sample-related problems are there, and we've kind of found ways to overcome that challenge to a certain extent, it boils down to the testing. there are a lot of labs that are mushrooming, that are not using, doing the right validation. So you're getting really poor quality next generation sequencing reports. And I know I always sound like a pessimist when I say this, but honestly, there are some really bad reports that come to our desk. And because quality is not maintained, be it the wet lab, dry lab, be it the entire bioinformatics pipeline, there are no trained individuals who are reporting it. And even in automation, which is what everybody comes and says, but ours is automated and we do the best next generation sequencing. If you don't have manual intervention of actually saying if the automation is going right, if all the results are right, you are going to have errors in it. So I think for me, one of the key areas that we're always having a challenge with is with the quality of the reports. There's misinterpretation. There is, a benign mutation, a VUS mutation being classified as pathogenic just because it happens to be near another, well-documented pathogenic mutation. So we do tend to see a lot of this. And I think that's one of the key areas that we struggle with in our clinic, is when we see one of these reports and then to tell a patient that, hey, sorry, but there's an error on this report. I know you've spent so much money, but now you have to go and do that. You've got to go and repeat testing or do something else. Now, that's from a very clinical standpoint. I think from a laboratory standpoint, what happens is that you're pressed for time. Your clinician wants a report urgently. Your patient is hounding you. And I can see how sometimes they hound us. But when they go to the laboratory, you can see, aaj chahiye, kal chahiye, my patient is, everybody's patient is not doing well. Even though the patient is perfectly fine at certain times, you'll get that my patient is not doing well. I need the report now. It's in critical condition. So I think sometimes what happens with the labs also, because they come under such tremendous pressure, they have to sometimes, I don't want to say cut corners, but they've got to do things a little bit quickly. So sometimes quality does get overlooked at, even though they don't want to do it, but there's just tremendous pressure that is coming to perform and deliver a report. So I think these are some of the key areas. With liquid biopsy, where my concern comes is that for liquid biopsy to not be inferior to tissue biopsy, based on which we can act on that report, depth of coverage, the validation has to be it has to be as good as perfect for us to bring it into a clinical setup. And a lot of times I do see in a lot of reports and validation data where people have cut corners just to bring it to the, to the table to bring it into clinical practice. So these are some of the real world challenges that we do face in our country. And I'm talking about our domestic partners. International, I think, is pretty well established, but obviously cost is a major issue. But with our domestic partners, having said that, can I also say that there's some people who do some really good work. So it's not everybody. There's some domestic partners who I think do a really great job and give us the support that we require for our clinics too. So it's not all bad.
Right. So I fully agree with you there, Dr. Parna. So let me come back to you, the three clinicians that we have in the panel. So how often do you, interpret the report all by yourself? Just go by what's written in the report? Because as Dr. Parna pointed out, sometimes there may be errors in the report itself. And I'll be coming to some of the reasons that could be leading to that. So do you pick up a phone and discuss with the molecular biologist, or what's your approach? Let me start with you, Dr. Runo.
Ma'am, for 60%, 70% of my patients, the report might be straightforward and might not need to discuss further, but around 40% of them, we do need the help from the molecular oncologist. And at times, that is why I agreed completely with Dr. Aparna, sending it to a reliable lab where we can have one-on-one discussion with the molecular oncologist is very important for me, because most of the times when the patient is coming up with the reports, we don't have any idea what to do about this report now, how to interpret the WAF, and so many mutations are coming with so much of comprehensive genomic profiles that we have in-house. So with that, it becomes really confusing for the clinician at times. So most of the times then the molecular tumor boards and discussion with the molecular pathologists come to our rescue.
Yeah, very true. So we have to really segregate VUS from the pathogenic variant for sure. Every alteration is not meaningful for a given case. So for that, we definitely would need to go back to the expert who really understands it all. Dr. Aarti, would you want to add something here? And then Dr. Devyani? Dr. Devyani?
Yeah, we actually just leave the report interpretation to our medical oncologists, so the ball is entirely in their court for this one.
That's honest confession. Yeah, that's being really honest. Yes. Yeah. So now coming to the last bit, the lab. I think this is very important, and we did hear from Aparna that, how do you choose domestic versus, more, say, US FDA approved labs, or within our domestic labs also, basis our experience and our experience with their respective reports. Over the years, we have our own, reliability quotient, I would say. So how to choose the right lab? And I think, Dr. Parna, I think you should answer this question as to what you see in the report given by a particular lab that makes you confident, that yes, this is the lab. This could be the go-to lab and not the other one.
So I think the first thing I'll always ask them is for the validation data. And in validation, it doesn't mean that they've done 5 samples and they've done head-on-head comparisons and said, oh, we did 5 tests and this is done. It's a proper, full-fledged validation. I want to understand their wet lab, dry lab processes. How do they prevent errors in there? Because look, human errors are bound to happen, and that's absolutely normal. Nobody's perfect. To err is human. But they should have checkpoints and mechanisms in place to prevent them. And if something does go wrong, how are they able to recheck and ensure that there are no errors? So understanding the laboratory processes, understanding the assays that they're using. Are they validated assays? How have they validated that assay if it's their own lab-developed assay? And publications. I think it's very important that when they're doing, especially something that they've developed on their own, it should be published in a good white paper, because when it's published, it kind of authenticates the work that they've done. Once you've got the assay bit sorted out, how are they reporting, right? So I'm going to come to accreditations in a bit, but with reporting also, which guidelines are they using? Are they using, for germline, it's ACMG, but when you're doing somatic, it is AMP, CAP, and ASCO guidelines. And there's so many times on somatic reports you will see, and this actually really irks me, is that they'll report a mutation and they'll say, as per ClinVar, and as per ClinVar, as per ACMG, this is pathogenic. That should not be in a somatic report. That is grossly wrong. So for me, that is, again, a huge, huge red flag with respect to a laboratory. Accreditations, we give it a lot of it being a minimum NABL, CAP accreditations, but I don't rely that much on it because, those are I mean, you can circumvent certain things and get your accreditations. We're quite sure on that. So it's not always the gold standard for me. It's important we get it because, at least the basic quality is maintained, but that's not my main flag, main green flag that I'm looking for. They should be willing to provide raw data, because if you're confident on your work, you're confident on your reads, I think giving your raw data so that we can analyze, have a look at it, kind of just builds that confidence. More importantly, they should be able to communicate with you. Some labs are very receptive. When you pick up the phone and you say, hey, I have a question, or something does not make sense, they are open to it. And if there is an error, and again, I repeat, errors are going to happen. They'll make errors, we'll make errors, all of us make errors. But you learn to grow from those errors, and you start saying that, okay, fine, I agree, this was a mistake. We made this error. This is how we are rectifying it. You kind of start trusting that lab because they know they're here to do good work, right? So I think communication is a very, very important factor. And then obviously your publications. I think how much a lab publishes and the kind of physicians they publish with, right? That also makes a huge difference with respect to the body of work that they're doing. So for me, these are some of the things that ideally I would like to look for in an ideal world. This is what I would be looking for, if that makes sense.
So perfect. You have covered all the points that came to my mind too. So it's very important. Each and every point listed here and said by Dr. Parna, they are all very, very relevant and important for us to decide as to which lab to choose for sending the CGP or NGS sample. So let me now come to the clinicians and a case. Dr. Runu, you could take this up. So a 65-year-old man presented with cough, breathlessness, biopsy done elsewhere, reported poorly differentiated carcinoma. There was a right lung mass with liver and adrenal mets, PS2. But when the NGS was ordered, they said sample not sufficient. So how would you approach this case if you were the medical oncologist that the patient consulted at this point?
I would repeat the biopsy, ma'am, and would like to send for the IHC and for the NGS as well with PDL1.
Mhm. Right. So you would not resort to doing a liquid biopsy here because you see a lot of tumor sitting there, which can be probably easily biopsied, right?
Yeah, if the tumor can be easily biopsied, my first preference would be to go ahead with the tissue biopsy upfront.
Right.
Only when the patient becomes reluctant that we don't want to go ahead with the tissue biopsy is that when we resort to liquid biopsy sometimes in the front line. Otherwise, always I prefer to go ahead with the tissue biopsy.
Yeah, for the known benefits of tissue biopsy. So this tissue biopsy was done in this patient, a bit complicated, not a straightforward case though here. And so this reported adenocarcinoma with focal areas of small cell carcinoma. And the IHC was also done, CK and TTF1 positive. And that focal small cell carcinoma area was positive for synaptophysin. And PDL1 was also done, 10%, and the NGS revealed EGFR mutation positivity, L858R. So how would you treat this patient? Dr. Aarti, if this patient came to you, is she around? I don't, Dr. Aarti, I don't see her. So Dr. Runu, you could continue.
Yes, ma'am. So, the adenocarcinoma with a small focus of small cell carcinoma, it raises the concern for the combined histology or a transformation risk for me. And with the EGFR positivity, I would target the EGFR first. I would go ahead with the EGFR TKI in this setting. If the patient is otherwise well preserved, I might like to combine it with the chemotherapy. So my first therapy of choice here would be osimertinib along with the pemetrexed and platinum.
Right. I would agree there with you. And we'll not confuse the issue. This was a difficult case, as I said. So we'll keep it simple for today. And these were some of the other alterations that were reported in the broad panel NGS. So, Dr. Aparna, what do you make of this report? So besides EGFR L858R, we see this P10, TP53. What's the significance of these?
TP53 is a resistance mechanism that could be there. So when you're giving, say, osimertinib or EGFR TKI, osi or whichever you choose, I would recommend chemotherapy in a case like this, especially in the presence of a TP53.
Yes.
P10, I'm not really sure if it's a resistance mechanism up front. I would double check that before I open my mouth, to be very honest. But over here, I would say TKI plus chemotherapy, and P10, I would check the importance of P10 in a case like this and then comment on it.
Yeah, bang on. And that's what I wanted to hear, that with this P53, what Dr. Runu suggested in the beginning itself, a combination of TKI with chemo makes all the sense. And so that's the way forward. And we would, that small focus of small cell carcinoma, I think, I don't know, but could be, left for some time alone and see as to, because they said it was a focal area only, right? And there's nothing in the NGS to suggest that small cell carcinoma should be the focus of treatment, isn't it?
Right, ma'am. So what we can do is keep a close watch on the while we are treating the patient, and at the time of progression, we may repeat the biopsy and see for the
Yes.
transformation. Yeah.
Yes, yeah. So I think we would all agree there. This is another quick case, a 55-year-old man diagnosed with metastatic non-small cell lung cancer. Biopsy confirmed adenocarcinoma, PDL1 10%. NGS hotspot panel was done, KRAS mutation. Patient was given chemoimmunotherapy, had partial response, received maintenance therapy, but after 10 cycles had progressive disease. Repeat biopsy was done. and a liquid biopsy was sent. This is the liquid biopsy report. So Dr. Runu and then Dr. Aparna.
So, ma'am, here I can see BRCA2 mutation, though the amplification, what I see here is around 0.4%. I'm not really sure about BRCA2 mutation in lung cancers and whether I could consider it as clinically significant. I think Dr. Aparna might guide us better here. But as of now, what I would choose is with the standard, maybe second line of chemotherapy with the docetaxel and ramucirumab is what I would choose here after progression on IO and chemotherapy. But I think we would love to hear from Dr. Aparna how to
What about
interpret this
these PARP
BRCA2.
inhibitors, not in second line?
I am not really sure for the second line, ma'am. Yeah.
Yeah. So Dr. Aparna, 0.4% cell-free DNA.
That's a pretty significant number. This is, I think,
A
one of the
liquid
older.
biopsy, yes.
Yeah. It's a pretty significant number. I do recognize the lab, so I know this is a reliable lab. I do know the I do know the VAF is pretty reliable, so I would act on it. Now, what's interesting, and we're starting to see a lot in the absence of an oncogenic driver in lung cancers, we are starting to see a lot of BRCA2. So I at least in a month, I'll see 2 cases, non-oncogenic driver, and I'm seeing a BRCA2. So BRCA2 is also a known germline event that can lead to lung cancer. There's a lot of emerging data there. But for today, since it's lung, I'm just going to stick to the somatic part. These tumors are usually sensitive to platinum chemotherapy. And I think there was a trial, it's called the Saphiro,
Yeah,
something
Saphir
like
trial.
Saphiro-02,
Perfect, yes,
something like
Saphir,
that.
SAFIR, Saphir
Yeah,
trial.
there was some trial like that. And I remember in that it was platinum chemotherapy and they did give a PARP inhibitor. I think it was veliparib or something like that. So they
Yes,
did
yes.
give a PARP inhibitor and there was a pretty decent response from what I remember. So in cases with lung cancer where we do see these BRCA1 and especially BRCA2 mutations, the way to go forward is one, try platinum chemotherapy. If the patient has a good response to platinum chemotherapy, then maybe try doing an HRD signature. There are some labs that do it in a more agnostic form for other tumor types and not just for the classical HBOC cases. If that HRD signature comes back positive, then go ahead and give a PARP inhibitor. That's one way of doing it, or you can follow the Saphir trial. And I think that was a combination of PARP and platinum.
Yeah, so bang on there. So that trial is correct, as you said, and you rightly pointed out with the CGPs that we are ordering, we are more likely to see these alterations. Now, I'll close in interest of time with one comment from all of you about the liquid biopsy. How firm a believer are you in the utility of liquid biopsy in non-small cell lung cancer? Dr. Runu, Dr. Devyani, your final comment, and Dr. Aparna then, and then we close. Since I don't see Dr. Aarti here. Yeah.
So I am doing liquid biopsies for those patients who have progression on the first line standard of care. For those patients to look for, because of the heterogeneity, sometimes the tissue biopsy is not an option for some of the patients, or sometimes we try to combine liquid and the tissue biopsy also. But upfront, for most of my patients, I am sticking to the tissue biopsy as far as possible.
Mm-hmm.
I'm not yet using it for the response to therapy. I'm not sure if anybody else is using it for for evaluating the response to therapy, but this is what I'm using it. Mainly for the, if the patient is on EGFR or ALK at the time of progression to look for the resistant mutations, of course, that time the clinical utility is of course there for the liquid biopsy. And at the time of progression, if the tissue is not an option for us, then again, I'm using liquid biopsy.
Mm-hmm. Dr. Devyani, you could comment on the utility of liquid biopsy or any other comment that you wish to make about today's topic.
I agree with Dr. Runu. Actually, even in our setting, we use the liquid biopsy only when we run out of options for a tissue biopsy. And some very rarely we come across cases which have been treated elsewhere without a proper diagnosis. And by the time the patient reaches us, there's been response at most sites which said there was tumor. So these are those one-off cases where we rely on a liquid biopsy. But upfront, I think we still stick with tissue biopsy.
Mm-hmm. And Dr. Aparna, if you could list 3 advantages of liquid biopsy.
Okay.
Yeah.
So a couple of things. One, it's definitely non-invasive. Two, I do feel it helps tackle the issue of tumor heterogeneity. And I always go back and quote the IASCLC consensus that came out and now is even in our NCCN guidelines. In an ideal world where cost is not an issue, we have a fantastic paper by Dr. Sanjay Popat that shows that upfront complementary testing of tissue and liquid in lung, and again, I repeat, where cost is not an issue, is the most ideal way to go forward in molecular profiling for lung. But if cost is an issue, the recommendation is even if you do tissue, if the tissue does not give you an oncogenic driver, reflex is liquid. And if you do liquid upfront and it doesn't give you an oncogenic driver, then you do a reflex tissue, unless tissue is not possible. But I think today, if you've done a baseline tissue, on the next progression, a good liquid biopsy would most likely be my preferred way forward, because you do have the ability, unless you feel clinically that the patient is maybe having an oncogenic change, or you see something in the patient that you feel that maybe this is not classically EGFR, something is there, or you want to do an IHC after that, then obviously you do tissue. But otherwise, I think liquid biopsy would be a fabulous, fabulous weapon that we have in actually understanding the biology of the tumor. And coming to Dr. Runu's statement on, are we using liquid biopsy for treatment monitoring? Not yet in lung cancer. I do know in colorectal, we are doing by looking at the change in the amplification number of HER2, and based on that, we're escalating or de-escalating the drug dosage with respect to that. But I think in lung, we're getting there. There is some role of liquid biopsy, even in minimal, with respect to minimal residual disease. I think it was the TRACER-X trials, if I'm not mistaken. Maybe not the best outcomes. It's still work in progress, but I think liquid biopsy is a fabulous tool that we have in NSCLC. And we're going to start seeing a lot of it even in our stage 3s going forward. Stage 3, stage 2, and when we're in that conundrum, liquid biopsy, I think, is going to be one of our key tools.
Yeah. So rightly said, and I would end here in interest of time. And thank you, Dr. Kanika, for the opportunity. And thank you all the panelists for your contributions. Thank you.
Thank you, Dr. Jyoti, and all the panelists. I think the 2 cases which you discussed really put in a good framework of our real, practice nuances which we face in the clinic, because next genome sequencing is something even patients demand nowadays. And as doctors, we really need to have a lot of clarity, the right lab, the right sample. Unless we are clear, we will not be able to offer the right test. So thank you so much. I think we are very well in time. And now I will request our next speaker, Dr. Jovita Martin Daniel, who is a senior consultant from the MGM Cancer Institute in the Department of Medical Oncology, for her talk on reinventing adjuvant therapy in EGFR mutation, non-small cell lung cancers. Over to you, Dr. Jovita.
Can I just share my slides?
Yes, please. And in the meantime, I request all the attendees and panelists, if you have any questions, please do type in the chat box. Maybe we can, have a conversation towards the end of the talks.
So are the slides visible?
Yes.
Okay.
They just need to be in the slideshow mode.
I've already changed it. I think it will just come up now. Is it now visible?
Yes, yes, absolutely. Please go ahead.
Okay. Yeah. Good evening, everybody. I just made a very surprising transition from MGM to Adyar Cancer Institute as professor, and I'm really glad to have the opportunity to speak amidst a very light group of beautiful, intelligent, empathetic women pan-India who are in oncology and oncology research. So just going on to the topic, reinventing adjuvant therapy in EGFR mutated early lung cancer. The slides are not moving. Yes. The survival outcomes, as we all know, in resectable NSCLC needs to be improved. And you're aware of the lung cancer rate. It's around 1.8 million deaths annually, 80% of them is NSCLC and 30% of them are actually resectable. But when we look at the 5-year overall survival, we see that in stage 1B, actually it should be 100%, but look at the rate, it's only 65 to 75%. Stage 2, here again 50 to 70%, and stage 3A, 30 to 45%. So which means very clearly, there's something that is there that we are not really addressing, and that's why this talk. So testing the recommendations in early lung cancer. So we're not just extending the check for PD-L1 and EGFR and so on and so forth just for the metastatic cancers. We also do so for non-metastatic resectable lung cancers. And we see that if they turn out to be EGFR positive, then Odora backs us up for an adjuvant Aussie. And if it's going to be EGFR negative and PD-L1 positive, we have other backups like for Atizo, Empower 10, and pembrolizumab, Keynote 91, and Alchemist trials for Pembro and Evo. If it's going to be EGFR mutation and PD-L1 negative, then we have no other choice but to give chemotherapy. So the current testing and treatment pattern, the prevalence of EGFR mutated patients in resected stage 1 to 3 non-squamous NSCLC results of the early EGFR study, which was actually presented in ASCO 2023. The study actually was taking place between March 2021 and October 2022 in 33 centers in Middle East, Africa, Latin America, and Asia. What they alluded to is that EGFR mutation prevalence was in 51% with deletion 19, and L858R was in 50%. So kind of equivocal, but positive trend toward deletion 19. So the study also revealed that more than 2/3 of the patients who underwent only surgery, that is 73.2% of the patients, and only 46.3% of the patients received adjuvant systemic therapy. So there is a flaw here. So not everybody is consolidated. So therefore, when we look at the results, after initial treatment, more than half of the patients with resectable NSCLC experience recurrence within 5 years. So 40 to 50% of them remain cancer-free and 50 to 60% of them recur. So given that over half the patients recur after a curative intent surgery, there is an unmet need for improvement in both neoadjuvant and adjuvant treatment options in order to improve the survival. Let's look at this age-old ANITA study, which was adjuvant chemotherapy after surgery for stage 1B to 3A NSCLC. It definitely gave us the improvement in the overall survival and the disease-free survival, about at least 5% after 5 years. And this study basically had an 840 patients, and there was the use of 30 milligram per meter squared of vinorelbine plus cisplatin 100 milligram meter squared 3 weekly. And it definitely, you see the curves diverging. So there's a 5% improvement. But let's look at what backed us up for adjuvant TKIs. Now, the study still now, whatever we have had, it was only on erlotinib, and then we had for geftinib. And in all these trials, the TKIs were actually given after the chemotherapy. So Select, Radiant, and Ivan, these were the 3 trials which were using erlotinib after adjuvant chemotherapy plus minus radiation. It did demonstrate a bit of DFS, but not OS. And so also, we had adjuvant CTONG 1104, a Chinese trial, and the BR19. Both of these trials used geftinib after adjuvant chemotherapy, demonstrated DFS, but not OS. So when we collectively look at this DFS data obtained by these 6 randomized trials, we see that the forest plot is clearly favoring the TKI use with a 48% reduction in the risk of disease recurrence. When we look at the OS, it is not actually demonstrative, but the HR was 0.64. But there's a point here to know is that the reduction in the risk of recurrence mattered with the sequence that was used. Suppose adjuvant TKI was used versus chemotherapy as the first line of adjuvant, 57% reduction in recurrence took place. But if the TKI was given after the adjuvant chemotherapy, the risk of reduction was only 38%. So which means here, we shouldn't be all the time barking on chemotherapy. So we should have proper trials designed with TKI upfront and the adjuvant setting. So why did these data not result in a change in the clinical practice in all our guidelines? Is because the trials to date have a limited design and size, no OS benefit, and it delayed it was unclear if the adjuvant EGFR therapy would cure or delay the recurrence, and no definitive period of treatment, as in if it was 2 years or 3 years. Now going on to Adaro trial, this was a trial which was recruiting completely resected stage 1 to 1B to 3A NSCLC with or without adjuvant chemotherapy, including more than 18 years of patients, except in Japan and Taiwan, where more than 20 years patients were recruited. The performance was 0 or 1. And the patients had confirmed EGF, exon 19 deletion or L858R. Brain imaging was done and a complete resection with negative margin. And if the maximum interval between surgery and randomization, 10 weeks without adjuvant chemotherapy and 26 weeks with adjuvant chemotherapy. There were 682 patients randomized as a 1:1 fashion. And the treatment was for 3 years, and the follow-up was for 5 years. The primary endpoint was DFS, and the secondary endpoint here was OS, safety, and so on and so forth. So when we look at the Adara trial, the DFS and the OS actually started being very pronounced from the first 3 months of recruitment. The primary endpoint, which was the DFS, did not include the stage 1B, but the secondary endpoint included the stage 1B as well. Because 1B is a group where even without treatment, we expect a good survival. So that's why probably the primary endpoint was not included. And at the end of 4 years, 70% of them were alive with OC, and placebo, 29% were alive. At the end of 5 years, 85% of them was alive with osimertinib and 73% with placebo. When we look at the impact on the CNS DFS, here also there was improvement, even though we know that CNS metastasis is actually a very poor prognostic factor, leading to deterioration of quality of life. Osimertinib has a very good blood-brain barrier penetration, and we all know about it. It's got a high exposure in the brain, and we see a demonstrable DFS with the CNS, and the DFS in months has not yet been reached. Looking at the safety analysis, we are aware of the GI toxicity and other toxicities. Here in this study, we have not seen anything new to quote as an adverse event, even though we saw that there's a little bit of discontinuation, dose reduction, and interruption with the osimertinib arm, which is slightly more than the placebo arm. This is acceptable. And the only serious adverse event which was noticed and the cutoff of OS was 2023 was COVID-19 pneumonia, but this also was later dismissed off because the patient recovered and it was actually not an osimertinib side effect. So the key takeaway points here is in order to improve survival, we definitely have to have more efforts to identify lung cancer early and to offer the tests in terms of knowing the molecular actionable mutation, and we need to have a collaboration with a multidisciplinary team in order to improve the survival. And having a cancer-free, prolonged life, the good survival benefit is what we're working at. And that will be the goal for the patients as well as for the treating physicians. Thank you so much for patient listening.
Thank you, Dr. Jovita. Very, very crisp and a great presentation. I think the felt need of adjuvant after radical treatment, whether it be CTRT or after surgery, was existing for good 3 decades. And now with these TKIs and immune checkpoint inhibitors coming in, we have a lot in offering for our patients. And with that, I think I would open the house for some questions. Do our audience or panelists or other faculty have any questions in mind? Please take this next 2 minutes till the time Dr. Mubarak sets up her slides. Any questions? So I believe no burning questions as of now. So that gives me the opportunity to invite our moderator for the next session, which is on redefining the EGFR mutated stage 3 non-small cell lung cancer management, a new benchmark. And for the moderation, I request Dr. Mubarak, who is from ACI Kumbala Hill Hospital, Mumbai. I believe the designations are correct. Tarunji, please do take note. There are affiliations which have changed, which need to be updated, as I understand. And to join her for the panel, we have Dr. Chinmay Agarwal, who's a consultant medical oncologist at Sarvodaya Hospital, Noida. Dr. Pallavi Redu, consultant medical oncologist at Kailash Hospital, Noida. We have Dr. Akanksha Chabra, who's a consultant medical oncologist at DMCH Cancer Center and AOI Ludhiana. We are also joined by Dr. Anita Malik, Senior Consultant and Clinical Head, Radiation Oncology at Fortis, Noida. Dr. Priya Ish Punyani, who's a Consultant Thoracic Surgeon from Asian Cancer Institute, Mumbai. Dr. Disha Tiwari, who's an Associate Consultant Medical Oncology at Max Hospital, Vaishali. And Dr. Niharika Bisht, who's a Senior Consultant Radiation Oncologist at R&R Hospital, New Delhi. And we also have Dr. Sabina K. Chaudhary, who's a Consultant Medical Oncologist at RGCI. So I really feel happy introducing this panel because, many of the panelists have been colleagues, have been students, and it's really a very happy sight to see them at these platforms and deliberating on such pertinent topics. So over to you, Dr. Mubarak.
Thank you, ma'am, and thank you for having me over here. And let me, I hope all my panelists are around. And let's start this topic. We'll have a discussion on EGFR mutated stage 3 non-small cell lung cancer management. We know that stage 3 lung cancer, non-small lung cancer, is a heterogeneous disease, and it has like N2, N3 nodal disease, including. So the survival varies as we have stage 3A to stage 3C median overall survival ranging from 41.9 months to 11 months meager, and 5-year overall survival rate from 41% to 12%. So in management of stage 3 non-small cell lung cancer requires a multidisciplinary assessment, that is assessment of N2 nodal station, whether resectable or unresectable, and usage of adjuvant therapy after a surgical or non-surgical multimodality therapy. What are the key considerations when we look at managing these sort of patients? There are 2 factors, patient-related factors and tumor factors. Patient-related factors is ECOG performance status, weight loss, comorbidities, pulmonary function test, especially FEV1 more than 1, and also DLCO, which is very important, and cardiac function, patient preferences, social and financial factors. What about the tumor factors? The stage, whether it is stage 3A versus 3B or C, N2 bulk and number of stations. Is it technically resectable? Can radiation be delivered to keratosis? So this is a question to my panelists. I think we can start with Dr. Priya, if she's around. So
Yes.
are all...
Good evening.
Hi. How are you, doctor?
I'm good, thank you. How are you?
Fine, I'm okay. So are all these stage 3 discussed in MDT in your hospital? Is unresectability for stage 3 determined in an MDT?
Yeah, so this is a very important question, and it's actually asked in most of the webinars or panel discussions. So the answer to it is academically yes, practically also yes, but it's not a routine MDT like it's held in an academic institute, because our MDTs are many a times not in a conference room or a room with a cup of coffee. It is routinely on the phone. We call our medical oncologist, radiation oncologist, and our radiologist mostly across the phone. We pick up a phone and we talk about the patient. We discuss about the patient. Because our OPDs are not packed like the government institute or like Tata Hospital. The OPDs are really packed. So they have a joint clinic. That's a good venture to have, every daily joint clinics, which it's difficult for us to have. So normally, yes, all these patients, stage 3 patients, are dealt with an MDT, which is the right way to go, because a lot of things now can be offered to the patient if 4 heads are put together for one patient. So yes, it's personalized, and a personalized treatment is offered to a patient.
Dr. Anita Malik, if you can take the first question. What about in your organization? You discuss all this stage 3 non-small cell lung cancer in MDT, and do you determine unresectability in the same setting?
So, yeah, good evening. Ideally, on baseline, this should be discussed, and most of the cases we discuss in the tumor board regarding the resectability, and then we move forward for going for a CTRT or a neoadjuvant therapy. Yeah.
Okay. So now the question two is, Dr. Chinmay, do you perform biomarker testing across all stages of non-small cell lung cancer patient?
Good evening, ma'am. Yes, ma'am. In our daily practices nowadays, we have started doing biomarker testing across all the stages, because the adjuvant data has come for osimertinib, then durvalumab. So, like durvalumab for CTRT in stage 3 is for like adjuvant irrespective. However, if at all there are financial crisis, then if at all it's a very high PD-L1 staining, it gives you a better thing to explain to the attender that you know this will be a much more beneficial kind. Apart from that, yes, biomarker testing also we are doing it across all the stages.
Including stage 1?
Absolutely, ma'am. Yes.
Okay. And Dr. Akanksha Chabra, if you can answer the same question.
Hi, good evening, ma'am. Ma'am,
Right.
so basically, if we look at the stage 4, so yes, a broad panel NGS testing we do in all patients with PDL1 testing. But in early stages, I only go for EGFR and ALK mutation testing, because PDL1 is not required. Irrespective of it, I will be giving. And because of the financial issues, I usually only do EGFR and ALK in the early stage setting.
What is the method you employ, doctor?
Ma'am, so NGS in the stage 4 setting, which will include everything with PDL1.
In stage early stage disease.
And in early stage disease, so if I'm not doing NGS, so I'll do EGFR by PCR testing and ALK mostly by IHC, because it will give me the report upfront in early days.
Okay. So the next question is for Dr. Shweta Arya. What are the imaging tests do you order in stage 3 non-small cell lung cancer, apart from a chest CT scan?
MRI brain, ma'am.
Yeah, that's good. In all stages of non-small cell lung cancer, you are supposed to do an MRI brain, including a stage 4 disease.
Yes.
So this is our first case. 62-year-old lady. She's a non-smoker, presented with persistent cough, no hemoptysis. She wasn't a smoker. A baseline CT scan showed a right middle lobe mass. And the baseline PET CT scan is here as well. It was T2B, 4.5 centimeter lesion, N2 multi-station lymph node. Biopsy positive for adenocarcinoma, TTF1 positive, P40 negative, EGFR mutation negative, ALK negative, PDL1 15%. So how do you proceed next? This is the question is for Dr. Priya. So which modality of therapy would you choose amongst them? chemoradiation followed by consolidation immunotherapy, surgery followed by adjuvant chemotherapy and immunotherapy, neoadjuvant chemoimmunotherapy followed by surgery, or perioperative chemoimmunotherapy with surgery.
So I assume a mediastinal staging also has been done,
Yeah, it's
which confirms the
multi-station.
Yeah. Yeah. Okay. So yeah, since the immunotherapy has come in, there is more role of surgery even in bulky N2 now. Previously, bulky N2 used to go for chemoradiation. Now with immunotherapy coming in, we have more role of surgery in immunotherapy patients. However, whether we go for neoadjuvant chemotherapy, immunotherapy only followed by surgery or perioperative, I would go for perioperative chemoimmunotherapy, but I would discuss the options with the patient and the medical oncology, to be frank. But yeah, I would recommend, I would prefer a perioperative chemoimmunotherapy, but I would discuss with you actually before I go.
Thank you. And Dr. Niharika Bist, if you could shed some light, how would you approach this case?
So with the multiple N2 nodes positive on PET scan, there's a high clinical suspicion, ma'am, that the patient will, if undergoing a mediastinoscopy, will concur the same. So yes, the data for chemoimmunotherapy in tumor sizes more than 4 centimeter and lymph node positivity is definitely very attractive. But I think the option of definitive chemoradiotherapy followed by durvalumab is more time tested, and probably I would offer that first to the patient.
Okay, Dr. Anita Malik, ma'am, how would you go about?
Yes, so I agree with Dr. Niharika. If this case would have like single station nodal disease, we can choose for a neoadjuvant chemotherapy because this is multi-station nodal disease, and maybe this patient is inoperable because multi-station disease is there. So, and the chemoradiation is time tested, and we need more data, mature data for neoadjuvant chemoimmunotherapy. So maybe we will wait for some time for this second option.
Okay, so this case was before before we had data of agent or checkmate studies or pembrolizumab study of
We have data
perioperative
We have time and tested data, I think, right?
We have the data now. Those
Yes,
that especially 3 doses of, even the agent data, as well as the data from
Checkmate.
pembrolizumab and checkmate. We
Yes.
can introduce chemoimmunotherapy followed by surgery. Plus minus maintenance immunotherapy is depending on the trial design. But this case was before these trial data were had come out. So this patient went on to receive definitive chemoradiation. So I want to ask my panelist, Dr. Pallavi Redu, in your practice, ma'am, what's the most common regimen of chemoradiotherapy you use? Dr. Pallavi? I guess madam isn't there. So Dr. Disha Tiwari, if you can answer this. Most common regimen of chemoradiotherapy. I think probably you're on mute, Dr. Disha.
Hello. Hi, good evening,
Yeah.
ma'am.
Hi, good evening.
So you are asking me the most common regime. So we use most commonly paclitaxel and carboplatin. That is most commonly used along with the radiotherapy. With paclitaxel being 50 mg per meter square and carboplatin with AUC2 weekly regime is much more preferred. This is the most common clinical practice that we have in Max Hospital, Vaishali.
What about concurrent or sequential chemoradiation? How do you prefer it?
Concurrent is much more preferred. We plan our patient with the concurrent chemoradiotherapy rather than sequential. We have seen much more tolerated, and we can manage the side effects much better. So in our practice and in our setup, we use the concurrent chemoradiotherapy.
Dr. Shweta Arya, madam, if you can answer the first question, what are the most common
Yes,
regimen in your
ma'am, the most common regime used is paclitaxel and carboplatin.
weekly?
And regarding concurrent, yes, ma'am, weekly. And regarding concurrent or sequential, concurrent is preferred, ma'am.
Okay. Now the next question is to Dr. Shabina Chowdhury. What are the preclinical evaluations you do before starting your patient on chemoradiotherapy?
So the baseline lab investigations we do, and most importantly, we usually do a pulmonary function tests also for every patient before we move on to all these modalities. So I think that's also very important. Apart from basic lab.
Yeah, we need to do a pulmonary function test, including a DLCO, and document it before proceeding with chemoradiation. What about ma'am, Dr. Niharika Bish?
Same, ma'am. We follow up first with a CBC and a good PFT and a DLCO, ma'am, and start of CCRT.
This patient was initially started with sequential chemoradiation, was given 2 cycles of cisplatin pemetrexed, and after 2 cycles, this is his post-induction chemotherapy imaging. As you can see, there is reduction in the right middle lobe mass, and also the mediastinal lymph node size has decreased. Subsequently, she went on to receive concurrent chemoradiation, and at the end of the definitive chemoradiation, there is complete response in the right middle lobe lesion as well as the mediastinal nodes. So, Dr. Anita Malik, ma'am, in your practice, how many patients do complete all the doses of chemoradiation?
So with the newer radiation techniques, the tolerance is very good. The side effects, toxicities are very less. 10 years back, we are seeing patients who are getting sequential chemotherapy followed by radiation. But now these days, we are treating in lung cancer, approximately 60% of the patients we are getting concurrent. And as they, with the advent of these targeted durvalumab and these therapies, the number of concurrent chemoradiation therapies, number of patients in per month, that has increased.
No. I think you're mistaken. The question: how many of your patients are able to complete all the doses of chemoradiation?
So almost all the patients. So we use adaptive radiotherapy for larger tumors, and the tolerance is much better with the these days, the newer advent of newer techniques.
So all your patients go on to
Yes.
complete started definitive chemoradiation.
Yes.
Okay, and the question is to Dr. Niharika Bisht as well. What about in your practice, ma'am? How
I'm
is
almost with the newer techniques, as well as because paclitaxel is a very well tolerated regimen, which does not show much immunosuppression. I believe around 90% of my patients complete CCRT with the caveat that they are PS1 to begin with and have a healthy baseline weight, ma'am.
So what's the most common reason for dropout from chemoradiation in your practice?
In my practice, it is esophagitis, ma'am. They have really, bad loss of appetite and difficulty in swallowing. So not exactly dropout, but that is the first cause of a long treatment break. And second would probably be, nausea, vomiting, and myelosuppression, ma'am.
Not pneumonitis?
No, ma'am. I think probably it would be around, 10, it's 5% to 10% who would come with, as a subacute complication rather than an acute complication with pneumonitis, ma'am.
Okay, after completion of radiation, you mean to say?
Yes, ma'am.
Okay, so my next question is to Dr. Pallavi Redu. How do you assess patient outcomes in patients who do not complete definitive CTRT? I think madam isn't there. So this question I'll pass on to Dr. Disha Tiwari. Dr. Disha, are you around? I think Dr. Shabina Chowdhury can answer this question. How do you assess patient outcomes in those who do not complete definitive chemoradiation?
So you mean to say radiological assessment or health-related outcomes? What are the
Health-related outcomes. How do you think, I mean, do they do better compared to those who complete radiation or not? That's all.
that I think we need to evaluate our complete data set. So we don't have so many dropouts actually in.
No. This is not like in your organization or institute. This is in general.
So as a matter of fact, people who do not complete CTRT, they usually do worse than the people who have completed. But
yeah, that's right. They are not able to complete the
and
therapy.
if we like stop RT prematurely or something like that, so outcome will definitely be similar to a palliative intent treatment. So.
Okay, I had a very interesting case. She was a 60-year-old lady, stage 3C non-small cell lung cancer, given sequential chemoradiation, I think 1 or 2 cycles, because she had very bulky nodal disease. The radiation oncologist wanted a sequential chemoradiation. So, but she received therapy in Nashik. She could not complete definitive chemoradiation at all. She had very bad cytopenias, and she was given initially only 2 cycles of weekly paclitaxel carboplatin. With she barely completed, I think, 3 to 4 weeks of radiation. In the interim, her EGFR mutation came positive for deletion 19, and after 1 month of completion of her radiation, she was still sick. She had fungal pneumonitis. We started her on osimertinib. Unfortunately, within 3 months of osimertinib, she had progression. I haven't seen a patient on osimertinib progressing in 3 months. We got a biopsy done, and unfortunately, the biopsy showed a carcinosarcoma variant. So it was a very aggressive disease to begin with. So this is one of the cases where, patient is not able to complete chemoradiation and has progressed quickly on osimertinib. And the next question to Dr. Dr. Akanksha, what's your next line of management post completion of definitive chemoradiation?
Ma'am, so in these sort of patients, I always do EGFR and ALK testing upfront. So if the patient has completed post chemoradiotherapy, I would reassess the response. If there is good response, then if the patient is EGFR ALK negative, I would proceed with the immunotherapy. And if the patient is EGFR positive, now we have good data that we should start them on osimertinib rather than going on immunotherapy.
Yeah, that's exactly correct. And Dr. Chinmay, do you have similar thoughts?
Same, ma'am. If at all the patient is all markers negative, EGFR ALK negative, then we'll straight away go ahead with durvalumab maintenance. If at all the patient is EGFR positive, then we'll go ahead with osimertinib maintenance.
So in the real world, the completion rate of CTRT was different from what my panelists discussed. It was somewhere between 60 to 80%. Maybe this was because of older technology of radiation and use of different variety of chemotherapy regimens as well. As you can see, there were completion rates. This is United Kingdom single center data. You can see patients, those who could complete both were, 63.8%. Radiation alone was this much, and couldn't complete both were 7.8%. So then again, a PROCLAIM study is a randomized phase 3 trial of pemetrexed cisplatin or etoposide cisplatin plus thoracic radiation followed by consolidation chemotherapy in locally advanced non-small cell lung cancer. As you can see, this is the pemetrexed arm, the arm A, and arm B is the etoposide arm. So the higher number of patients in etoposide cisplatinum were able to complete the number of cycles as opposed to pemetrexed platinum. We're going to discuss very quickly PACIFIC trial design. This is a stage 3 locally advanced unresectable non-small cell lung cancer who had not progressed following definitive platinum-based concurrent chemoradiation and performance status of 0 to 1. They were randomized within 6 weeks, 42 days post definitive CTRT, durvalumab 10 mg per kg every 2 weekly for 1 year versus placebo, 2:1 randomization. The primary endpoint here was progression-free survival. Other key secondary endpoints were overall survival, duration of response, safety, tolerability. This is the 5-year PFS data of this trial, which showed durvalumab had median PFS improvement of 16.9 months, whereas in the placebo arm, it was only 5.6 months. There was almost tripling of the PFS, and the hazard ratio for progression or death was 0.55, which is actually significant. It showed a sustainable and durable PFS of 33.1% at the end of 5 years. What about overall survival? Again, overall survival was better, 47.5 months with durvalumab and 29.1 month median OS with a hazard ratio of 0.72. And at the end of 5 years, it was 42.9% versus 33.4%. There was a significant improvement in overall survival also. Now, when you look at patients, those who were EGFR mutated subgroup in this Pacific trial, you can see the median PFS is poor in patient those who were EGFR mutated is 10.9 months versus 11.2 months. And also median overall survival was lesser, 43 months in EGFR mutated population versus 46.8 months. This showed that EGFR mutated subgroup do not benefit with addition of durvalumab maintenance after completion of definitive chemoradiation. So based on these conclusions, durvalumab consolidation has become a standard of care in unresectable stage 3 non-small cell lung cancer. However, we do not consider this durvalumab consolidation in EGFR mutated population. So we have already discussed this. So this is the current NCCN guidelines for management of stage 3B and 3C and 3 disease. So N3 positive go on to receive definitive concurrent chemoradiation. If they are EGFR negative, they go on to receive durvalumab. Osimertinib is administered if it is EGFR exon 19 deletion or L858R mutation. So my next question to Dr. Shweta Arya, what is your current line of management in patients with or without genomic alteration in this scenario?
Ma'am, we offer durvalumab, but in practicality, hardly 30 to 40% of my patients continue with that. I'm practicing in a tier 2 city, so my majority of my patients, they have financial issues.
No. What about with genomic alteration, that is actionable targetable mutation?
Ma'am, we give the option if EGFR positive, ma'am, we give the option of osimertinib. And now we have upcoming data of lorlatinib also in ALK mutation. So we offer, ma'am.
Okay. And if there is no genomic alteration, you consolidate it with the durvalumab.
Yes, ma'am.
What about Dr. Akanksha Chhabra?
Yes, ma'am, I have already answered this. So basically, if patient have genomic alteration like EGFR or ALK, so I will not counsel for immunotherapy. If patient can afford EGFR positivity osimertinib, then I would like to go with that. Now we have upcoming data, the ALINA trial for the ALK positivity also. I have not used in any case till now, but osimertinib for EGFR positive, yes. If not, then durvalumab for 1 year.
My next question is to Dr. Anita Malik. How do you manage patients if they have progressed on consolidation therapy, that is consolidation durvalumab?
So when the patient progress on systemic therapies, so
no, consolidation durvalumab.
Okay, so in progressive sites, we can consider the patients for radiation, consolidated radiation. Last year, the one study was published, that is NRGL 002, in that the patients who has progressed on systemic therapies, we can consider for re-radiation or sort of 30 gray or 40 gray radiation to those sites.
This
So
is oligometastatic disease.
oligometastatic. So we can give local therapy in the form of radiation to those sites.
Okay.
If these patients progress. Yeah.
So what about Dr. Disha Tiwari? Hello.
Yes, hi
How
ma'am.
do you manage patients, those who have progressed on consolidation durvalumab?
So it will depend upon the type of progression. If it is oligometastatic, I agree with Dr. Anita Malik ma'am that we can consolidate, we can re-radiate the patient depending upon the site of recurrence, or if it is not coming in the previous field, then probably we can re-radiate the patient. And if it is oligometastatic, definitely we'll try to again treat the patient with the definitive intention. But if it is frankly metastatic disease, advanced metastatic disease, I would like to go ahead with the biopsy and the molecular analysis again, just to see the receptor status of the patient and what's the PD-L1, current PD-L1 status, and what is the current molecular alteration or the genomic alteration present in the patient. Then I'll proceed with the further treatment depending upon the genomic alterations.
So I think we are clear here. If it is an oligometastatic progressive disease, you would want to radiate if it is not in the radiation field. And if it is a disseminated progression, we would like to rebiopsy and look at genomic profiling and consider therapy based on those results. Our second case, 52-year-old gentleman, non-smoker, investigated for a left upper lobe lung lesion. He was also found to have hilar mass and bilateral mediastinal lymph node. He had no other risk factors and no comorbidities. So you can see a baseline CT scan as well as baseline PET CT scan, which shows presence of left upper lobe lung mass and bilateral mediastinal lymphadenopathy. Baseline MRI was negative for metastasis. The biopsy was positive for adenocarcinoma, TTF1 positive, P40 negative, ALK was negative. In the lung biopsy specimen, surprisingly, PD-L1 was 0% and 80% positive in EBUS lymph node from the station 4L. Tissue NGS testing was positive for EGFR deletion 19. So he was final diagnosis was CT4N3M0 adenocarcinoma of the lung. This patient was given 2 cycles of chemotherapy and subsequently he was administered concurrent definitive chemoradiation. At the end of his concurrent chemoradiation, you can see the PET is cleared. There is some fibrosis of the mass and there is no uptake in the nodes. So what's your line of management for EGFR mutated post chemoradiotherapy? I think we have all discussed now in patients those who have targetable alteration, it is better to expose them to subsequent TKIs. For example, in EGFR mutated post chemoradiation, we offer osimertinib. How do we monitor patients post completion of chemoradiation? This question is for Dr. Niharika Bish.
So post completing chemoradiotherapy, ma'am, we for the first 2 years go ahead with 3 monthly CT scan, and of course an SOS scan of the brain, the MRI if the patient is symptomatic. Other than that, in clinical practice, we don't go ahead with anything. A CT scan is good enough for us. Of course, if the patient is losing weight and he has other multiple complaints that point towards metastasis, then we order a PET scan, ma'am.
What about Dr. Shabina Chowdhury? Madam, how do you monitor patients after completion of chemoradiation?
Yeah, so initially we do 3 monthly CT scans, and then by the next year we do decrease the frequency.
Yeah, most of the guidelines do recommend imaging chest CT scan every 3 monthly in the first year, followed by 6 monthly in the next 2 years, and SOS PET CT scan. PET CT scan is not in the guidelines for surveillance. How long do you wait before initiating consolidation therapy post chemoradiotherapy? The question is to Dr. Akanksha Chabra. In patients who do not have any adverse events as opposed to patients with grade 1 or 2 pneumonitis.
Ma'am, so the trial has shown that we can start in 1 to 42 days. But what I practice in my clinic is that I go for the consolidation therapy after 3 to 4 weeks after I have reassessed that there is no progression on the CTRT. So that is when I start after 3 to 4 weeks.
And Dr. Disha Tiwari?
Yes, consolidation therapy usually is offered after completion of 4 weeks, that is post 1 month after completing chemoradiotherapy. Most of the patient we start starting from week 5 of completion of chemoradiotherapy. If we are offering durvalumab, we would like to wait for 4 weeks at least so that patient recover.
No.
Yes.
Okay. Go on. Yeah. In people who have had grade 1 or 2 pneumonitis.
In patient who had grade 1 or grade 2 pneumonitis, I would like to wait for probably extend the initiating immunotherapy, particularly at week 5 or week 6. Usually we don't start before week 4. And still, if the patient is having pneumonitis, I would be skeptical starting it before week 6. So I'll wait till week 6 and then I'll assess the patient's chest. We'll go ahead with the CT again and to see the pneumonitis. If it is settling, there is no residual disease, and if the PFT is also okay, then I would like to offer the patient immunotherapy.
So you'd like the pneumonitis to get back to grade 1 or grade 0 before initiating consolidation
Correct,
therapy?
ma'am. I would not be in a rush to start the consolidation therapy.
So this is LAURA trial data in patients, those who went on to receive maintenance osimertinib after definitive chemoradiation. As you can see, this is the key inclusion criteria. Stage 3 non-small cell lung cancer, which was advanced unresectable, exon 19 deletion or L858R mutation had to be positive in the tumor blocks. Maximum interval between last dose of chemoradiation and randomization was 6 weeks. So here the cutoff was 6 weeks, just like Pacific trial data. Osimertinib and placebo randomized 2:1 randomization. Treatment was continued until disease progression or toxicity or discontinuation due to any reason. This is an open label osimertinib after and also patient those who had progression were offered osimertinib in both the treatment arms. The CT was done every 8 weeks to 48 weeks, thereafter every 12 weeks until disease progression. Primary endpoint was median progression-free survival. Secondary endpoints were overall survival, CNS data. So this is well-matched population. As you can see, the exon 19 deletion and L858R were almost similar. And response to prior definitive chemoradiation was CR, followed by 40% to 37% partial response, stable disease in 43 to 51 patient. There is no progressive disease, of course, and not evaluable in 8% of patients each. They were very well balanced with respect to most of the factors. When you look at this PFS curves, they are very, very widely separated. 2-year PFS rate was 65% as opposed to placebo of 13%. You can see the median PFS is nowhere close, 5.6 months with placebo and 39.1 month with osimertinib, and a hazard ratio of 0.16. This is like, Crown trial data where you have a very hazard ratio of 0.12. Very rarely you get such a good hazard ratio. And what about Per investigator, it was similar to the blinded independent committee review with a hazard ratio 0.19. Median PFS was 38.9 months versus 7.3 months. There was 62% improvement in 2-year PFS. And when you look at various subgroups, it is osimertinib definitely does better in all the different subgroups. What about the tumor burden? And if you can see the objective response rate, again, it's higher with osimertinib, 57% versus 33%. Disease control rate is 10% higher. Median duration of response, of course, it's higher, 36.9 versus 6.5. It is 6 times higher with osimertinib. What about the subsequent site of metastasis? As you can see, the most common site of metastasis was brain, 29%, whereas in the osimertinib arm, it was only 8%. And subsequent lung mets were seen in 29%, whereas in the lung, it was 6%, followed by liver and lymph nodes. So definitely the new lung lesions as well as brain lesions were less in osimertinib arm as opposed to placebo. This is a very interesting curve, interim analysis of overall survival. We do not have a mature data for overall survival, but this is interim results which was presented in lung cancer meeting in 2025 at maturity at 31%. You can see the osimertinib median overall survival was 58.8 months. With placebo, it was 54 months. There was only improvement of 4 months of OS. As you can see, there are crossing over of 81% of patients, those who had progression, did go on to receive osimertinib. This is why the data is
Hello,
like,
ma'am.
1 second, just give me a
Yeah, sure.
नंबर क्या है इसका? Keep quiet. I'm sorry about that. So how do you interpret the efficacy data? So there is PFS improvement, but there is no overall survival improvement. The question is to Dr. Disha Tiwari.
Hello, ma'am. Ma'am,
Hi.
we are running out of time.
I think I guess I can conclude it. Probably you can go on
Sorry.
for yeah, no problem. Yeah. I'm closing it in the
Can very much appreciate the multitasking women are doing at home. Late evenings meetings are not easy to handle. So thank you so much, Dr. For your wonderful moderation. And I request Dr. Runu. Dr. Runu, are you there?
Hello.
Yeah, Dr. Runu.
Hi, ma'am.
Next speaker.
Yeah. So the next speaker is Dr. Rashmi Shukla. So ma'am will be talking about the role of SBRT. I think we'll not waste any further time and I'll just quickly call Rashmi ma'am.
Okay, thank you. Thank you, Dr. Runu, for giving me this opportunity.
Hi, ma'am. Good evening.
Hi, Runu. I'm just started sharing my slides. Full speed? Is it full speed? So my topic is an SBRT in lung, evolving indication, integration with systemic therapy. Am I audible, Runu? Hello, Ronu?
Yes, ma'am, you are audible, ma'am.
Okay. So as we know that non-small cell lung cancer is the leading cause of cancer-related death in US, and approximately 20% of patients are diagnosed with early stage disease. And in India, 90% are inoperable. So since decades, the gold standard is surgical lobectomy, but the patient in which having the worst health status, sublobar resection or radiation is also an option. So we can say in early stage, SBRT is safe, effective, and efficient treatment for early stage NSCLC. So what does SBRT exactly do? So it causes immunogenic cell death, abscopal effect, and microenvironment modulation. So radiation work as an immunotherapy with so many increased expression of MHC1 and all induction of apoptosis and all like that. So when is the SBRT era considered for the consideration of SBRT for early stage NSCLC? Just a bit. And should we even consider the adjuvant systemic therapy? So as we know, the principle in SBRT is we deliver very high dose of radiation to the tumor with extreme accuracy and with a new very few fractions of treatment and with a shorter treatment course, and we reduce the side effect and higher tumor control rate. So let's start with in 2010 and 2014, the Timmerman and Riccardi, they both conducted a phase 2 trial in which we compare the SBRT with surgery in operable stage 1 NSCLC, and they both found that there is a significant difference in overall survival of around, and it is equivalent to surgery. So these are the selected trials. So many trials, they have proven that they shown the local control rate of 85 to 95% at 3 to 5 years and 50 to 95% at 3 years for early stage NSCLC managed with SBRT. So these are the RTOG trials of SBRT lung, in which they have taken the size criteria of less than 5 centimeter, and these all trial, they have shown that the 2-year local control is more than 70%. But yes, the challenges are treatment related toxicities like pneumonitis, esophagitis, chest wall invasion, as well as the patient selection criteria is very, very important, and to decide for adjuvant treatment. But yes, the advancement in treatment modalities in the different advanced radiation techniques, decreasing the toxicities, and also we can even have a very good quality of life as well as less toxicity after the treatment. As we know in lung cancer for SBRT, this slide is very, very important because the doses, toxicity, and everything depends upon the location of the tumor. If it is peripheral located more than 2 centimeters from proximal bronchial tree, oh, we are safe and we can give a very high dose of radiation safely. But the challenges come for the central lesion or the ultracentral lesion. If the lesion is directly abutting the proximal bronchial tree, sitting on it, then there is high chance of perf and all, and so many complications are there. So let's start for the indication of SBRT in early stage lung cancer. So most established SBRT criteria include N0 patient with less than 5 centimeter periphery located tumor. As we have seen that so many trials and RTOG, they have put the size cutoff criteria of less than 5 centimeter. But we are also cautiously treated with expanded tumors of size within 7 centimeter of size, central, ultracentral, multiple synchronous lesion, as well as chest wall invasion, as we know that it has some inferior result. So for peripheral, it is very nice, 12 gray per fraction or like that. It is very safely we can give. But for central and ultracentral, the dose is reduced, as well as we will increase the fractionation, like what we give 50 in 5, 64 in like that, but here we are giving 60 in 8 or even in central or ultracentral, especially in ultracentral tumor, we are very worried. So we fractionate 60 gray in 12 fraction or might be to the 15 fractions. So many trials are ongoing. So there is a sunset trial for ultracentral tumor, which is addressing the dose fractionation of 60 gray in 8 fraction. I found there is few more papers for the mediastinal and hilar lymph nodes for SBRT, and here you can clearly see that 35 gray in 5 fraction, but not up to 40 gray, because there is a risk of TOF, hemorrhage, hemoptysis, as well as esophagitis. But yes, we are in our institute also, we are doing mediastinal and hilar lymph node metastasis. One case we are recently completed, like RCC, having the lung mets as well as hilar and mediastinal nodes, to giving 35 grain 5 fraction. So coming to the patient selection criteria for SBRT, sitting in an OPD on the Monday morning, patient come to us, and then how we will decide. So mostly safely we can say that stage 1 or 2, that is T1 to T3, even up to less than 7 centimeter, but yes, safely less than 4, less than 5 to 3 centimeter, it will be more convenient. NSCLC who are medically inoperable or high risk elderly, like PFT or FEV1 or DLCO less than 40 centimeter, 40%, diabetes, coronary artery disease, cerebellar disease, pulmonary hypertension, and all in very high risk elderly patient. NCCN since 2013, I remember in my classes, they say patient who refuses surgery after appropriate consultation, that is also an indication for SBRT. Yes, oligometastasis, oligoprogression is there. So compromised pulmonary function or limited lung reserve where surgery poses significant risk of post-operative complications. So coming to the recent NCCN guidelines, yes, 1A, very nicely they have said ki if it is inoperable, high risk of surgery, or patient refuses for the surgery, SABR is a definitive radiation, preferably SABR is preferred. And same slide it is. So even in stage 1B, T2, T3, or up to T3, but N0, yes, SABR is preferred, but we can add some adjuvant chemotherapy. So coming to, this is about the indication of SBRT. Now discuss about the adjuvant therapy after SBRT. So how the concept came? The concept came as the local control in early stage NSCLC after SBRT is very high, but distant failure always remain an issue. And adjuvant therapy aims to eradicate micrometastatic disease and improve long-term outcome. So let's discuss with this. So this paper, JCO, they have shown that in spite of SBRT, the most important pattern of failure is distant failure in 30%. Second paper also, they have reported 46.9%. So the role of adjuvant therapy or any systemic therapy is required when we see the pattern of failure. As we know that these all adjuvant chemotherapy trials after surgery like GLACE, meta-analysis, JBR.10, they all have shown that there is a 5% improvement in overall survival at 5 years in stage 1 NSCLC. Same ANITA trial and CalGB trial have shown it. So in systematic review, the advantage of adjuvant chemo in early stage is well established. And in these cases, they prefer adjuvant systemic therapy. So some of the patient, even they have just given the EGFR mutated DFS, they have given erlotinib, but DFS has favored, but not statistically significant. So as discussed, ADORA trial, osimertinib in stage 2 is stage 1 to 3, stage 1B to 3A. It has shown a very, very good result. So we can have seen that NCCN also recommend that in any tumor more than 4 centimeter or 1B onward, some sort of adjuvant systemic therapy is needed. So this is a paper which has shown that adjuvant they have all in systemic therapy, they have all given cisplatin based chemotherapy. After SBRT, it has shown a good result. And SBRT followed by chemo was associated with improved survival, especially in tumor more than 4 centimeter with N0 disease. But yes, they have also shown that smaller tumor, they don't have much survival benefit of adding adjuvant chemotherapy. Another trial, they have also shown the same result like in stage 1 or tumor more than 4 centimeter, SBRT plus chemo, they have shown a better overall survival. Another paper in the RIS2 2017, they have shown if the tumor is more than 5 centimeter, even the chemotherapy is associated with improved overall survival. In MA 0.02.07, it is a phase 1 trial. They have done a trial with immune checkpoint inhibitor with SBRT. Even they are trying as a new adjuvant, concurrent, and adjuvant with atezolizumab. Enrollment are going on. This trial also, they have used a cisplatin-based chemotherapy after SBRT, and they have shown excellent local control and improved survival in T1 to T3, N0, M0, NSCLC. So, another phase 2 trial, they have used nivolumab to SABR in early stage node negative NSCLC. They have given SABR alone of 15-4, or 17-10 with nivolumab. And they have shown a very good event-free survival rates and 4-year event-free survival with not significant toxicity. So in selected cases, we can say that combined approach of SBRT with adjuvant systemic therapy in high-risk patients with molecular alterations, yes, it has some benefit, but yes, more studies are needed. And it should be discussed in multidisciplinary tumor board about the timing and sequencing of SBRT with adjuvant systemic therapy. And we have to also take care about the treatment related toxicity. That is the most important factor, and to enhance treatment efficacy. So this I have shown it. So some trials, they have also shown that especially in central tumor, SUV more than 10, high risk, they might benefit from SBRT with adjuvant ICIC. Yes, oligometastasis, we are doing PDL1 positive tumor is there. So these are the future trials like Keynote 867. They used Pembro plus, they are all ongoing trials. Pembro plus SBRT. Pacific 4, they have used post SBRT in stage 1 durvalumab. Alliance, the science timing of SBRT with atezolizumab, even they have tried as a new adjuvant or concurrent, and some trials exploring SBRT with ICI with VEGF inhibitors. So to conclude, SBRT is an effective treatment option for early stage NSCLC, offering comparable outcomes to surgery. Adjuvant therapy plays a crucial role in improvement in resected NCLC, so we can take data and we can have that same thing with SBRT. But yes, integration with adjuvant therapy, it should be discussed in multidisciplinary tumor boards to decide. And it should be offered to all high-risk surgical patients for patient not willing to surgery, lobectomy, and refusing surgery. It is an excellent treatment approach. And SBRT has now also a developing role to boost following definitive chemoradiation in management of locally advanced NSCLC and in re-radiation of locally recurrent disease as well as intrathoracic oligometastasis for various primary histology. Thank you. Thank you once again, Dr. Runu, for giving me this opportunity. Thank you.
Thank you so much, ma'am. It was an excellent presentation as always. And I especially want to thank you for accepting our request for this talk in such a short notice. And it is always a pleasure to listen to your talk, ma'am. And in the interest of thank you so much, ma'am. In the interest of time, I would request if you have any questions to please post it in the chat. So thank you once again, ma'am. Then over to the organizers for the next talk.
Dr. Runu, please introduce the next speakers as well.
Yeah, so next is the panel discussion about SBRT lung. So for that, I would request Dr. Vinita Goyal ma'am to take it forward.
Good evening, everyone. I hope I'm audible to you.
Yes, ma'am, you are audible.
And my slides are visible as well, right?
Yes, ma'am, they are visible.
So thank you, Dr. Kanika and Dr. Runu, for giving this opportunity to me. I would now like to invite the panelists. Okay. So Dr. Srinath is a medical oncologist from Kolkata. Dr. Aditi Tanwar, radiation oncologist from Delhi. Dr. Monica Malik, she's a radiation oncologist from Hyderabad. Dr. Ramba Pandey, radiation oncologist from AIMS Delhi. Dr. Jaspriya Bal, she's a nuclear medicine specialist from Delhi. I hope everyone is there. I have kept only two small cases for discussion. We have to answer this question of SBRT lung, who, how, and when. So there are two cases. One is a primary lung cancer and the other is a metastatic lung cancer. So I'll start with the first case. The first case is a 80 years old gentleman. He has a history of heavy smoking in past. He landed up in a multi-specialty hospital emergency with complaints of shortness of breath. 1 second. So he landed up in hospital emergency with complaints of shortness of breath and chest pain. So as would happen, immediate cardiac triage and ECG were done and both showed an abnormality. And following this, an emergency coronary angiography was done. It showed a triple vessel disease. And immediately the same night, angioplasty was also done for this patient. His chest X-ray was done after the angioplasty procedure, which revealed a left lung mass. And after that, for left lung mass, he underwent series of investigations. Eventually he landed up doing a FDG PET scan. My apologies, I couldn't locate the image of the FDG PET scan. I'm just showing you the image of the CT scan. So the FDG PET scan actually showed a 3.5 into 2 centimeter necrotic soft tissue lung mass with a high SUV of 14.4. There were no significant mediastinal lymph nodes and there were no distant metastases. So I would first like to ask Dr. Jaspriya. Dr. Jaspriya, please accept my apologies that I am not showing you the correct image. But
No problem, ma'am.
Thank you so much, dear. My point is that, some of these patients, they are very unfit. They have a history of heavy smoking in past, ILDs, COPDs. They are more prone for pneumothorax, and especially if a biopsy is done, sometimes the recovery can also be challenging. Suppose tissue is not required for doing NGS for somebody who's not affording for any, immunotherapy or targeted agents. Can we go ahead with non-surgical treatment based only on a FDG PET scan report, especially in a country like ours where, tuberculosis is also so common? We are a tropical country.
So that's what you answered my question, ma'am, because we, in our country, the infections, especially tuberculosis, are so rampant and most of the times picked up on CT chest, even when we are doing PET CTs for other malignancies. So ideally, yes, we have to prove the malignancy before going ahead for the treatment. We just can't take it on the FTG PET to be a malignant pathology.
But sometimes I find that, your eyes, they are able to say this is infective. For us,
Yes, yes. We can. We are like almost 100% sure, but then there have been occasions where we have been proven wrong, especially when we have suspected metastasis in a other primary, but that it just came out to be a reactive or a infection in the lung. So that's where we know that it's better to prove.
Best to prove. So if you can safely put in a needle, it is best to prove and not rely only on the FDG avidity. Although your nuclear medicine specialist can guide you, understand whether this looks inflammatory, infective versus malignant or not. So for our patient, blood thinners could not be stopped because of his recent coronary stenting. Surgery was, however, ruled out because of recent coronary stenting. So we somehow managed to get a FNAC of the lung mass, which proved it to be squamous cell carcinoma. So this is his image in the mediastinal window or a soft tissue window. This was the location of the tumor. And this is actually the collapse part, the distal atelectasis. The same lesion can be seen in the lung window also. So it was pericardiac in location, central lung lesion, T2N0 squamous cell carcinoma, medically unfit for surgery. So I think, as Dr. Rashmi has just now alluded very nicely about the role of SBRT, I will come to my radiation oncologist. I'll start with Dr. Ramba. Dr. Ramba, sitting in AIMS, how would you approach this patient? Hi, Ramba.
Hi.
A conventionally fractionated RT versus SBRT, and what is the evidence in favor or against conventionally fractionated RT?
Ma'am, in this patient where there's so much of cardiac morbidity and the tumor being so close to the heart, this patient is an 80-year-old gentleman.
Yeah.
Right? So it's better to go ahead with the SBRT rather than going ahead with the conventionally fractionated, because whatever said and done, whatever we do in conventional, the heart is going to receive a significant dose if we are planning with the conventional radiotherapy. Whereas if we are going ahead with the SBRT, probably we will be able to save the heart to the maximum and minimize the dose. So in this patient, SBRT would be a better option than going for the conventional radiotherapy.
I agree with you. Dr. Aditi, any difference of opinion or any thoughts?
I would also agree that for this patient, ideally the best treatment would have been lobectomy plus lymphadenectomy. But since surgery is ruled out, so considering radiation, I would also like to go forward with the SBRT instead of a conventional fractionation. And as far as evidence is concerned, there is a trial, a phase 2 trial by the name of SPACE. And there is another trial, the CHISEL trial, and also the Luster trial, which have evaluated the importance, and they have shown how SBRT has proven better compared to conventional fractionation in terms of control of the disease and as well as OS.
So I think our panelists have given us two very valuable points. The first point made by Dr. Ramba is that in case we are doing a fractionated RT, patient will have to come for 6 weeks of therapy, which is a long treatment for an 80 years old gentleman, and the heart would receive a reasonably high dose of radiation therapy. The second point made by Dr. Aditi is that other than the convenience issue, considering the age, etc., or the cardiac doses, etc., there is also a scientific evidence in terms of 3 randomized trials, which have all shown that Luster, Chisel, and Space trial, which have all shown that SPRT gives better local control rate and comparable survival with less toxicity as compared to conventionally fractionated RT in an early lung cancer. So science also supports the use of SPRT, as well as the convenience or the social factors also support the use of SPRT in a medically inoperable early stage non-small cell lung cancer. I think I'll now come to Dr. Monica Malik. So Dr. Monica, in your department, how do you approach lung SPRT patients? I have written few points like what is your motion management protocol, simulation, fractionation, etc.
Yeah, so this would depend on what the patient can tolerate. And then the second thing is what infrastructure is there in your department in terms of what motion management technique that we are going to use. And also, if we have 4D-CT or not, is the patient able to breath hold for a reasonable amount of time or not? So it actually all depends on that. There's no one size fits all.
Perfect.
And if the patient can breath hold, we would definitely recommend that as the first option. But given the case scenario that you have described, I seriously doubt this kind of a patient will be able to do that. So the next best option would be to do a 4D-CT and then delineate the ITV. And then have a tracking. RPM gating is what we usually do.
Okay.
And for a centrally located lesion, what is the dose fractionation you use, and what is the total BET that you aim for?
So for a central tumor, the dose per fraction between 6 to a maximum of 7.5 in 8 to 10 fractions.
Perfect.
And aiming for a BED of over 100.
Perfect. Dr. Aditi and Dr. Rambha, any other additional point other than what Dr. Monica has just now said?
So, ma'am, for the central tumor, maybe we can maximum dose what we give per fraction is 12 gray. So anything less than 12 gray is fine. So maybe 10 gray, 12 gray, or less than that, depending on the plan what you're getting. And BD, of course, as Dr. Monica told, we aim for a BD of 100 gray. So that's the thing which we go plan actually.
Aditi, any point from your side?
Ma'am, I think I would go for anything between 6 to 8 gray per fraction and somewhere around 8 fractions.
So I think I'll just show you what we did for this patient. We tried doing DIBH for this patient. In such kind of patients, in a lower lobe tumor, treating without a breath holding can be very, very tricky, because lower lobe tumors will have a lot of movement as they are close to diaphragm. See, so in such patients who are not very fit, we aim for very moderate deep inspiratory breath hold. Our goal is stabilization and not expand the lung or the volume of the lung. After a bit of a training, then we did simulation with IV contrast. The dose fractionation that we chose was 60 gray in 10 fractions. This lesion was quite close to the heart, so we did not think that it was suitable for anything above 6 to 8 gray, as Dr. Monica has also said. Our total BD10 was 96 gray. When we're looking at BD10, we should also simultaneously look at BD3, and our goal should be to keep the BD3 of less than 250 grays. We followed a protocol of 2 treatments followed by a 1-day gap. Fortunately, this patient this patient did not get any systemic treatment. And fortunately, there were no toxicities at all. And at the end of 3 years, he's fine. He's doing well. And it's quite heartening to see him come back. Just want to emphasize that SBRT is different from IMRT and IGRT. There are some essential non-negotiable technical components of doing lung SBRT, which includes some form of motion management. It is not essential that we do breath holding for every patient. As Dr. Monica said, that we have to customize according to what is available in the department and according to what our patient can perform. So if you have tracking, go for tracking. If your patient can breath hold, go for breath holding. If your patient cannot breath hold, then consider doing a tight mask or abdominal compression kind of a motion management. And the last resort, if nothing works, would be ITV based treatment planning. As soon as we start going for ITV, which stands for internal target volume, which means we are accounting for the movement of the tumor, the volume of radiation increases. The volume of ITV and PTV increases, which limits us from giving the appropriate doses. So as far as possible, for a very small lung lesion, we can still do ITV-based treatment. But for a reasonably sized tumor like this, which is 3.5 centimeter in size, paracardiac in location, doing a ITV-based treatment can be very difficult. We might not be able to give sufficient doses. I also want to emphasize that SBRT is not IGRT. SBRT, your planning has to be more conformal with a very steep dose gradient, and you cannot and you should not venture into SBRT unless we have the facility for doing daily imaging. Onboard imager is there. We should not attempt for it. And we aim for a dose of more than 100 gray. But over the years, we've all learned that lung tumors can be divided into peripheral, central, and ultracentral. There are several definitions. The definitions are quite confusing. I have made a very simple algorithm for my own understanding that contour the proximal bronchial tree, give it 2 centimeter expansion. If there is a lesion which is abutting it, then it is central. If there is any lesion which is within this so-called no-fly zone, then it is ultracentral. and anything which is not abutting this no-fly zone is called peripheral. Accordingly, we can risk adapt our doses. For a peripheral tumor, you can use a as high dose as 12 to 18 gray. For a central tumor, we will limit ourselves to 7 to 9 or 10 gray maximum. And for ultracentral lesions, our dose per fraction as well as total BET is less. We do not aim for such high doses in an ultracentral location as it can lead to catastrophic complications. I'll come back to Monica once again. Monica, following up these patients after I'm sorry, I wanted to also ask a medical oncologist. Dr. Srinath is there. Hi, Dr. Srinath.
Good evening, ma'am.
Good evening. I'm sorry, I forgot to ask you this question that,
No worries,
suppose
ma'am.
you had seen this patient after SBRT, would you offer any kind of systemic therapy or just plain observation, or would you insist on doing liquid biopsy even if the tissue is not available for doing NGS?
Ma'am, in this scenario, even post SBRT, I would definitely ask for a ctDNA if possible, ma'am, if the patient is affordable. But looking at his age and the way he has outperformed, I think even observation is still an option, ma'am. But if any of the targetable mutations are present, in those cases, I would consider adding like osimertinib, or even we have, there are only two substrate positivity, either EGFR or ALK. In this scenario, I wouldn't consider immunotherapy. But if any of the things are positive, after patient's concurrence, maybe I would add.
Perfect. So Dr. Rashmi in her talk also gave a message that the pattern of failure in these patients shows that a good majority have a distant metastasis. So
yes,
in coming times, we need to identify a suitable systemic partner for these patients after SBRT of the lung. So as a radiation oncologist, I would still urge that even if we are doing radiation therapy, these patients need to be discussed in MTT and suitably refer to medical oncologist for consideration of NGS, liquid biopsy, and suitable systemic adjuvant therapy.
And one more thing also, ma'am, to add regarding role of chemotherapy also, even though he's 80 years old, I would consider the geriatric score assessment. So based on that, then I would consider if he's a fit candidate, maybe adjuvant chemo is also still an option.
Thank you. Thank you so much for putting that, bringing up that point. You're right. We
Thank
did
you,
not do the geriatric assessment. We should have done it. We'll take care of it in future patients. So I'll come back to my radiation oncology colleagues as well as Dr. Jaspriya. First of all, I'll ask the radiation oncology colleagues, how do you do follow-up of these patients after you've done SBRT? I mean, would you do CT scan test or FDG PET? What frequency? We'll start with Monica.
Yeah, so the medical oncologist brought up that point of systemic therapy, and I think if there is driver mutations, then we would definitely consider this patient for systemic therapy. Otherwise, we would be quite reluctant given the age and comorbidities. The first scan after the SBRT, we would prefer to do an FTG PET, but not before 3 months. So after 3 months, maybe around 3 to 4 months is when we would do the PET scan. And depending on how that PET scan looks, the subsequent scans, again, maybe every 3 to 4 months, depending on how the patient is doing, and either CCT or PET scan. But if he is not very symptomatic and is otherwise clinically doing well, not a candidate for systemic therapy, we wouldn't be following up very aggressively as long as he's not showing signs of deterioration.
Okay. Dr. Aditi and Dr. Rambha, any difference of opinion, PET scan versus CT chest?
Ma'am, I also. Shall I speak?
Yes.
So I also believe that a PET CT should be considered, and I think at a 3, 6, and 12 months interval, I would want to evaluate this patient if he is actually has done well after SBRT. And yes, a CT chest probably if the patient has some financial constraints or something. Otherwise, I would love to follow up the patient with PET CT.
Dr. Rambha?
Same, ma'am. 3 months we will be doing the first PET, and after that I would prefer to do at 6 months and 1 year, not very frequently. And because this patient is an elderly with so many comorbidity, we are not targeting. This is squamous cell histology. So even we are not planning that we will get any mutation and we are going to give any targeted therapy. So we'll just follow up 3 months, then 6, and then 1 yearly.
If we look at the guidelines or the recommendations, the guidelines do not recommend doing a PET CT scan because an FTC PET CT scan after lung SPRT can sometimes throw more questions than answers. And if you're doing FTG PET scan, then it needs to be interpreted with a lot of caution. I think if you're doing PET scan after the SPRT, then it is mainly to rule out distant metastasis and not to assess the local response. Dr. Jaspriya, what is any opinion from you?
Yes, ma'am, I agree with you because ideally a CT would suffice if we have to differentiate the post-RT inflammation in an FDG PET. We actually look more at the CT component of the PET CT rather than just PET because the post-RT inflammatory changes, which are more of a consolidations, they look more like bronchiectatic changes rather than mass itself. So just going by the FDG uptake does not say that there's a residual disease. We actually have to look at the baseline scan and we have to compare the findings with the baseline mass that it looked like, and we inexperienced hands and experienced eyes can differentiate between a post-RT inflammation and the residual or recurrence, but then not everybody will be able to do it. I think CT suffices, but PET CT will be confusing if interpreted by novice or a naive person. So that can be confusing actually. And just to add, because you've mentioned FAPI does not distinguish post in RT inflammation changes as propagated. Even FAPI shows significant uptake in the inflammatory tissue. So we advocate doing FAPI only in malignancies which have lower uptake in FDG, not for distinguishing between inflammation and recurrence.
Ma'am, I read somewhere, I do not remember the reference exactly, but that if the SUV is more than 5 on the PET CT, so it more likely indicates a recurrence. So maybe CT,
See, the SUV max is a very variable. It depends actually on a lot of variables. So it depends upon the timing of the scans, the dose which is given, the blood glucose levels. So we can't have a cutoff value. How we interpret FDG is on the Hopkins criteria, and Hopkins is a visual criteria. It's not a semi-quantitative parameters which define that. We compare the uptake with the background, and then if it's equivalent, if it's lower than the background, it's more likely to be inflammatory, and if it's double than the background SUV value, it's likely to be recurrence. But again, I'll emphasize, we do have to see the CT component because in our Indian population, superimposed infection inflammation is rampant. So SUV is not a good criteria for, at least for our population.
I agree.
Aditi, let me remind you, SUV is silly uptake values. As Dr. Jaspriya also correctly said that we cannot look at it in isolation. Dr. Jaspriya, other than looking at the CT images, other than SUV value, I think that these scans should be interpreted along with the radiation oncologist who's given the radiation therapy.
Correct. I agree.
And sometimes you have to even look at the radiation plan or superimpose the radiation plan. And sometimes even one follow-up scan will not give you the answer, and you have to repeat, after 3 months again, and then make a comparative assessment. It is quite difficult. My heart almost sinks when I have to look at a post SPRT scan because I know that I'm going to get a very confusing or a muddled picture, and it may not be clear. I thought that FAPI might be able to salvage this situation, but you're saying that even that does not help.
No, ma'am. FAPI actually does not solve the question of inflammation for sure.
So thank you. I think with this, we would like to summarize our case for SPRT for primary lung cancer. My final questions. What is the suitability criteria or indications for doing lung SPRT for primary lung cancer? Dr. Rambha, would you like to take this up?
Yeah, so basically any tumor which is less than 5 centimeter in a medically inoperable patient, or when the patient refuses surgery. So, and this has to be discussed in a multidisciplinary board also. Sometimes, occasionally, we can go for a larger tumor, 7.5 centimeter, when it is an absolute contraindication and to surgery, and patient has a significant comorbidity and we have to treat. So but this also needs to be discussed with the surgeons and the medical oncologists before we take up for the SBRT. Apart from that, other indications will be when there is a recurrence, there are multiple tumor and all those things. So these are the situations where we go for the SBRT.
Perfect. So Aditi, would you like to take up this question? What are the contraindications? When will you not do lung SBRT in a primary lung cancer situation?
Ma'am, I would say that we should be extra cautious when we are doing it for tumors which are more than 5 centimeters. And also the tumors exactly that you've shown that that are ultracentral and probably have invaded the proximal tracheobronchial tree. And also if the PS is not good. So these would be the contraindications for doing in SBR.
So well said. I think with this, we would wrap up this case and come to our second case. So our second patient is a 65 years old gentleman. There's no history of smoking in past. He's a absolutely non-smoker. In May 2024, he was investigated for cough and weight loss of 2 months duration. He underwent series of investigations which started from chest X-ray, then CT chest, and ultimately landed up doing a FDG PET scan. This FDG PET scan showed that there was a FDG avid left lower lobe lung mass with multiple bilateral mediastinal lymph nodes, right adrenal metastasis, and multiple liver SOLs, which reflected stage 4 stage 4 lung cancer, polymetastatic disease. And a biopsy from liver was done, which showed adenocarcinoma, TTF1 positive. So lung was probably the primary tumor, and EGFR mutation, exon 19 deletion was present in this tumor. So he was immediately started on osimertinib. So I'll come to our medical oncology colleague. Do you agree with this so far?
Yes, ma'am. I would agree with this, ma'am. The only investigation I would add would be an MRI brain to this, ma'am. Rest all is fine.
Okay, perfect. So we did not do MRI brain at that time point. After a year, he remained well for a year. There were few PET scans which were done, which all showed partial response. But 1 year later, very quickly, there was increase in size and FDG activity of the primary lung lesion, and rest everything was in remission. So it was oligoprogression or oligo-induced EGFR mutated lung cancer in a good performance status patient with a disease-free interval of 1 year. So Dr. Srinath, my first question to you is this too quick or was this on the expected lines? What is the PFS1 expected from osimertinib in a patient with exon 19 deletion mutation present?
With exon 19 deletion, especially when osimertinib is given, the median PFS is around 18 months, ma'am. So he falls somewhere between the range of 12 months. So in some of the patients, definitely this oligoprogression is seen. But one important thing to notice, he is PS1. But is he symptomatic, ma'am?
No, he was asymptomatic.
Yeah, so some patients do progress, but progression in primary is always questionable. So in those cases, definitely I would either advise a repeat biopsy or an NGS or a liquid biopsy. Because if it was an oligoprogression at a different site, I would still continue osimertinib. But in this scenario, I would still want to check whether there's any other off-target or on-target resistant mutation present. So based on that, if still he has only exon 19 mutation, then definitely I would still continue osimertinib. Maybe I would add chemotherapy based on his symptoms, and because he is in good PS, that second line therapy I would plan. Otherwise, if it was any other site, I would still continue the same, ma'am.
So you would want to repeat a biopsy?
Yes, ma'am. The first thing is I would repeat a biopsy. I want to know whether there is an on-target or off-target resistant mutation present.
Okay. And since this is a oligoprogression, this is a solitary progression.
Yes, ma'am.
Would you consider referring this patient for any form of local therapy, be it surgery, radiation, RFA, cryo, microwave?
Yes, ma'am. One of the options are definitely considering a consolidation therapy in this case. But prior to anything, I think I would get a liquid biopsy done in this case to know any other mutational status, ma'am. If the mutational status are the same, I think in that scenario, I would prefer considering a local therapy. But if the patient has developed any other new mutation like a T790M mutation or any uncommon ones, then I would prefer adding up with something.
Okay, adding something up like
I
chemotherapy or immunotherapy.
Yes, ma'am. Yes, ma'am. I would look into the PDL1 status also in those cases because right now we do have other therapies also. But just for a single oligoprogression, again, I would put this case in multidisciplinary tumor board. Only after the consensus for the treatment I would plan, ma'am.
So suppose this patient had recurred after a gap of 2 years.
Yes.
Your approach would be still the same?
Ma'am, irrespective of the duration of recurrence, ma'am, I would consider where the site of recurrence is. For example, if it is not the primary, if it's not a lung progression, I would have still continued with osimertinib and maybe to that local site, I would have given a local therapy. In those cases, I would have preferably given radiation. But because
How
here
would
the
it matter whether it is the recurrence in the primary or any other site? I'm still not able to get you there.
based on imaging, ma'am, based on imaging, I would get the imaging done. I would look where is the progression seen, whether it's a primary site progression or it's a metastatic site progression. Because currently we do have data in case of metastatic site progression, along with osimertinib, either you give a local therapy or add chemotherapy in those scenarios. But if it's a primary site progression, I would still want to get the NGS testing done, ma'am.
So this is his PET scan. It showed that, earlier also he had, in May 24 also he had a lesion at this site, which had regressed in size and metabolic activity and had now progressed. So this is the MIP lung window and FDG PET scan image. So this was the only site of disease. Dr. Srinath, I would like you to correct me, but there is a lot of literature which says that when EGFR mutated lung cancers acquire some resistance, even if you give them local therapy, maybe you can continue with the same systemic therapy for some more, stretch it for some more time till these patients acquire, complete resistance or have more progression. And then you switch their systemic treatment. This is one of the studies that I'm quoting. Then there are studies on osimertinib also with a similar concept that you can delay the change of systemic therapy by adding a local therapy to the site of oligoprogression. So would you not agree with this concept? Because
Yes, ma'am, I would totally agree with this concept also, ma'am. Because here the progression is it's just a single site or an oligoprogression. So in those scenarios, definitely, ma'am, these are one of the options. Currently, we don't have any randomized trial. All these data are more retrospective.
Okay.
But because it's a progression from the primary site, that's what is questionable. It was in a distant site. Right now, we don't have a data for this. Maybe in those scenarios, even with osimertinib, I would still give chemotherapy as one option. Looking at what is the site of progression, the size, the symptoms, and hello, ma'am, am I audible?
Yes, you're audible.
Yes, ma'am. So these are the factors I would consider, ma'am. First, I would consider the patient factor, his PS, performance status, and what are his symptoms. If he's really symptomatic at the local site, my first preference of treatment would be local therapy.
So for a symptomatic patient, there is no doubt that you would add local therapy. It is for an asymptomatic oligoprogression that we are discussing. Let me ask my radiation oncology colleagues. So starting with Dr. Aditi. Dr. Aditi, how do you think this discussion will go in your MTT, or what is your usual approach in such a scenario?
I would like to mention, I was reading something, then I came across this phase 2 RCT, wherein it was published in the Green Journal, wherein some stage 4 NSCLC who were like EGFR mutant, they received TKIs, and then they were like, if they had a stable disease or a partial response, they were 1:1 randomized to receive either these TKIs alone, and in the other arm, SBRT along with the TKI. And SBRT was given to like different tumor sites, and it was like wrapped up in 5 sessions, like 30 to 50 grays. And they found that the PFS as well as the OS was found to be better in the combined arm compared to the TKI alone arm. And not much toxicity was observed in either arm. So I would say that the addition of SBRT, it can significantly probably delay the onset of this acquired resistance to the EGFR TKIs. and along with the dual benefit of prolonging the PFS and OS. So I
So
would
that is kind of consolidation RT in areas of partial response. But here we have a situation that a patient who achieved complete remission after starting on TKI and is now showing a solitary progression. So would you consider doing a biopsy, change of systemic therapy, or addition of radiation therapy? Or as Dr. Srinath said, she said, first I'll do a biopsy and try to understand whether the patient has acquired some mutation or not. And based on that, decide whether to add local treatment alone versus local plus systemic treatment.
Definitely. I would also like to go ahead with the biopsy and understand the biology of the disease.
Okay. Dr. Ramha, any difference of opinion or any other?
Same. I would go for biopsy because there's an oligoprogression at the primary site. So we have to know that what changes, what is the mode of resistance and all those things, so that we can decide about whether we should continue with the targeted therapy or we should add some kind of immunotherapy or systemic therapy. Along with that, I would also like to add local therapy here.
Okay, so then, Dr. Ramha, I would like to ask you, what kind of local therapy would you add for this patient? Would you send this patient for a metastatectomy or a lobectomy? Or
No, because this was at presentation, the patient had liver mets, patient had mediastinal lymph nodes, and also patient has primary. So I would go for radiotherapy in this case, rather than sending the patient for metastatectomy.
Makes you
This
think
is
that
not metastatectomy, this is the primary site.
This is a primary site, correct?
If it was oligoprogression in a patient with the oligometastatic disease upfront, then probably I would have gone for surgery.
Okay. So we had a discussion in our tumor board. Our medical oncologist did not think that the biopsy was required. And we did not offer this patient surgery because, as Dr. Ramha also said, that initially it was a polymetastatic disease, and SPRT being a non-invasive approach, we decided to go ahead with that. And we, took up this patient for breath holding. He could do a reasonably good breath holding. So after that, we did a CT simulation. We contoured our GTV. We generally tend to take multiple breath holding scans and label them as BH1, BH2, BH3. Sometimes we take up to 5 scans with breath holding also. And we contour GTV in all these 5 scans, which helps us identify any residual motion or movement of the tumor despite breath holding. And then we gave a PTV, and then we gave this patient 50 gray in 5 fractions and have continued osimertinib. I do not yet have the follow-up of this patient. This is a very recent patient that we treated in our department.
I have one question to
Yes.
the medical oncologist only probably. Is there any role of double dose osimertinib in such cases?
So if it was only a CNS disease, in those
I know, but
scenario would have
there is a
definitely
role.
increased.
Is there
But
any role in extracranial site?
no, extracranial site, the dose, even now all the data is only for 8 mg, ma'am. If it was anything intracranial, definitely I would have increased the dose in that specific scenario. If it was only a CNS brain mets the patient has developed, so maybe then I would have increased the dose of osimertinib to 160. Then look for it. Even if it was symptomatic, I would have treated with steroids, started osimertinib. Maybe then I would consider radiation in that scenario. Otherwise, extracranially, I wouldn't consider, ma'am, increasing the dose.
Great question, Dr. Ramba. So I think I would just like to wrap up by
Dr. Vinda, ma'am, would you like to
Yeah, I'm
conclude
just
because
concluding.
we are running short of time?
Yes, I'm at concluding slide only. That case selection for SBRT or local therapy, even on oligometastatic disease, is quite essential. Only it should be offered only for patients who have good performance status with solitary or limited sites of disease, single or limited organ involvement, metachronous presentation, long DFI, and it can be considered for patients with immunotherapy or TKI with oligoprogression. So it should not be offered for any patient with oligoprogression. And I think SBRT has found its place because of its low toxicity, high local control rate, non-invasive treatment, and for both primary as well as metastatic lung cancers. With this, I would like to thank my panelists as well as organizers for this opportunity. If there are any comments, pressing comments from the panelists, then I would request them to make that. Otherwise, I wrap up from my side.
Thank you.
Thank you, ma'am.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you, ma'am, for the excellent case discussion and for sparing your time today. And I thank all the panelists for their active participation.
Thank you so much, Dr. Renu.
So, on behalf of the organizing team, my colleagues at Horizon, Vishal and Aditya, and of course, a big thank you to Dr. Runu ma'am and Dr. Kanika and everyone who participated today with the theme of Women for Oncology. Thank you so much. Till then we meet again. Stay safe, stay blessed. Good night to everyone, and very happy Dussehra to everyone out there. Thank you so much.